Morning.
Good morning. How is everybody today?
Good. How are you?
Good, good. Does anybody have any questions for me on your homework reading? Anything you don't understand, anything you got wrong, anything that we've gone over in class, or any general questions?
I didn't get it wrong, but I have a question. Could you go over the it's number 2. It says, what is the hormone that moves like glucose, cells, and energy? I know that's insulin, but could you go into that?
We're actually going to talk about
Today?
diabetes
Okay.
and insulin today.
Okay.
Yep, I've got a whole lecture on that.
Okay.
Yep. Insulin, think of insulin as a key that has to open a lock.
Okay.
Okay.
I always get that confused with the other one. Yes. the
Adrenaline, okay.
Yes. The adrenaline.
Yeah. There are tons and tons and tons of different hormones in your body, and they control processes. So you have adrenaline, you have ACTH, you've got thyroid, pituitary, acetylcholine, dopamine, insulin. I mean, the testosterone, progesterone, estrogen. Those are all hormones that control processes. They all do something a little bit different. CNAs don't need to know what hormones are. You don't need to know how they work. You don't need to know what hormone controls what process. But if you go into nursing, you're going to have to understand all of that. So that's going to be in your anatomy and physiology. So good morning. Yeah, chapter 4 is a little overwhelming. There's a lot of information in there. And it's a very, very general overview. If you go on for nursing, you have to have an entire year of anatomy and physiology before you even get into the nursing program. It's a prereq. So you're going to be studying the body systems and how they work for an entire year before you even get into the nursing program. Now, if you're going pre-med, you have to get an undergraduate degree in chemistry or the biological sciences. So you got to have 4 years before you get into, the medical training. So understand that we have one chapter. Okay. This topic is way, way, way more in depth than what you see in this chapter. And that's because it's not really relevant to CNAs. We don't make decisions. We don't solve problems. All we do is identify abnormalities and then report those. So we have to know what's normal to be able to recognize abnormal. And that's really what chapter 4 goes over. And we're going to talk about each one of those body systems at the beginning of class today, so I can explain to you what you needed to take out of chapter 4. Okay, good. All right. So let me go ahead and get your scores for chapter 4. Remember that this was on page 184 for your homework, and then the answer key is on page 201. Down here is your grading scale, or you can just tell me how many you missed. Michaela, Joan, Sheila. Thank you. Sheila, do you have 1, 2, and 3 for me by any chance?
Yes.
Okay.
Chapter 1. I got an 80.
Okay.
Chapter 2.
Good morning.
I got an 80.
Okay.
And chapter 3, I got an 85.
Thank you.
Yeah, I know this.
Tiara.
She's coming in.
Okay. Sebastian. Egypt.
Chapter 4.
Yes.
100.
And do you have 1, 2, and 3 for me?
Number 1, I missed 2.
Okay.
Number 2, 100.
Thank you.
And number
Okay, thank you. Damon? Thank you. Charlene?
Oh, she got an 85 too on the chat before we did it together.
Very good, thank you. Brianna? Very good. Simon?
90.
Simon, do you have chapter 3 for me?
Yeah, 100.
Thank you very much. Mackenzie? 80, thank you. Good morning. Yanizlith? 3, thank you. Nathaniel? Good morning. And Jocelyn? 85. And Vernaji? 80. Okay. Any other questions?
Just question. This is on chapter 3. It's probably not going to be an exam, but is the pronouns going to be on a curriculum?
Is the what?
Pronouns.
The pronouns.
Pronouns.
Like he, she, they.
Yeah, I don't know what is normal out there right now. The landscape is, kind of shifting and all over the place. So I have no idea what that's going to be dictated by corporate policy. Okay. So every facility will handle this a little bit different. Every region's going to handle this a little bit different. So yeah, just ask the nurse or ask the patient. I mean, that's where I would go for that information, is just ask the patient, what do you prefer to be called? Pronouns, preferred pronouns. Yeah, that's going to be dictated by corporate policy. And it'll be vary by region, I'm sure. But I'll give you an example of this, okay, that isn't emotionally charged, because right now the political landscape's a little all over the place, right? So my mom's name, her actual name, is Catherine. But growing up, she was always called Kitty, like kitty cat, because it's short for Catherine. Well, when my kids were little, in fact, my oldest son, when he was a baby, like year and a half old, we drove into her driveway. And of course, he couldn't say grandma. He was still too young. So he called her Emma. And that name stuck. So then she started going by Emma. And that is how she is known, is Emma. So when she goes to the hospital, if you call her Catherine, she probably isn't going to respond, because she's never been called Catherine. So, as she was growing up, she was called Kitty. So she would probably prefer to be called Kitty. But if you ask her, she'll tell you, please call me Emma. Because that's how she's been known for the last 35 years. Now, my granddaughter, when she was growing up, she didn't call her Emma, she called her Emmy. So now we've kind of switched to Emmy. That's kind of what she goes by now. But if you ask her, what do you prefer to be called? She'll tell you, can you call me Emma? Now, she'll probably tell you that whole story as to why you're calling her Emma, because she's proud of it, right? So this has less to do with politics and more to do with personal preference. We all have things that we like about ourselves and that we want others to recognize about us. Me, call me Patricia. That's what's on the book. You can also call me Miss Patty. That's how I'm known out in YouTube world. I am Miss Patty. Please don't call me Pat. I don't like the name Pat. So we all have ideas of how we want to be seen. So it doesn't matter whether it's, a nickname for your actual name or a nickname that you go by. It doesn't matter whether it's female related or male related. It all boils down to, what does the patient identify? What do they want to be called? Because I'm working with the patient, not the political structure. Does that make sense? And if you take the time to get to know your patients a little bit, not a lot, but a little bit, they actually become way more compliant. and way easier to work with, because you see them as a person, not just a patient. There's a difference there. Does that make sense? Is that good? Okay. Good question. But no, it probably won't be on the care plan. And that's generally, now, there are situations it would be, okay? In certain settings, there are situations where that will come into play. But as a general rule, go by your facility policy. All right. Any other questions? Any other questions? No? Okay, so let's get into some review. Chapter 4 was all about body systems, and there's 10 body systems, and we do kind of have to learn a little bit about what each one does. But let me give you an example of why this might be important. So let's say that there is a horrible car accident. I mean, just a horrible car accident up here at the next slide at Northcliffe. Okay. Now, you have to get to Firehouse Subs for some reason down at Northcliffe and Mariner. Okay. So you're headed there. For whatever reason, it's imperative. You got to get there. So you go out here to the intersection, and there's a horrible accident, and traffic is backed up in both directions. You are going nowhere, but you've got to get to this destination. You can't get there through the accident. You have to figure out what to do, how to reroute, where to go. Now, Google Maps will help with that, obviously, but that one event is going to cause all kinds of problems for all kinds of things. So the trash pickup might be running late because they were stuck in traffic. An ambulance may not be able to get through to go to a chest pain call. They're held up. They have to go around. We might have a helicopter that's tied up because they have to come pick somebody up. So that one event, that one single event, is going to have impacts on multiple different people. Make sense? Now, if in the accident, a UPS truck was involved and it was absolutely destroyed, caught on fire, now that the stuff that was in the UPS truck isn't going to be delivered, and that's going to cause an even bigger mess, isn't it? Because more people are going to be involved. People all the way across town that had nothing to do with this are going to be involved because they're not getting their packages. Make sense? Okay, if you have a problem here, you are going to have effects from that. Even though this is the problem, you are going to have effects that may reach out beyond that system. And it will affect other systems. Just like an accident isn't confined to just that geographic location, there are outside effects that you may not see or think about. Any one of these systems that gets affected with disease process or injury will cause effects in other systems because they're not going to be able to do their jobs effectively without the input from this one. Does that make sense? They are all tied together, just like a community. We're all tied together. And it's important that we understand that, because if we have somebody that's in for, let's say, a heart condition, their kidneys might be affected. Their eyesight might be affected. Now, what does the eyesight have to do with the heart? Well, it's all about blood flow and vessel size. If the heart isn't beating strong enough, it's not going to get the blood to go up very well because against gravity. And if the vessels are small, there's more pressure in there. They're constricted. Remember, we learned about that with blood pressure, and it's going to have more force to push the blood through those small vessels. Well, the vessels in your eyes, super small. So we got to have enough force to get the blood there. So if we have somebody with a heart problem, a weak heart, their vision might actually be affected. Now, you as a CNA, you're not going to know all that. You're not expected to know all that, but you are expected to understand the care plan because the nurse knows all that. And they will have things in the care plan related to what is going on with this particular patient based on all of their body systems, not just the one that we're currently treating. So a question I get asked quite a bit is, what's the difference between nursing and medical? They're two totally different things. Totally different things. Now, they work in the same place, but the best way for me to describe this is think of building a house. Now, we built our house about 5 years ago. And when you're building a house, you have to have somebody to lay the foundation. You have to have somebody to build the walls inside, the framers, put the roof on. And you have to have plumbing, and you have to have electrical, and you have to have drywall. You got to have all these things to make your house, right? All of these different things. Well, you can't expect the plumber to do the job of the electrician. They don't know how. It's not their specialty. So medicine is geared toward figuring out what's wrong and fixing that thing. That is what medicine is geared toward. Figuring out what is wrong and then fixing that thing. Well, I just told you that if something is wrong, it could affect other things. Yeah, medicine doesn't really care unless it becomes a problem. Now, nursing, on the other hand, nursing is not geared toward figuring out what was wrong and fixing that thing. Nursing is geared toward all of these systems and making sure while they're getting care for this one thing, that the rest of these systems are being monitored and cared for. So medicine is diagnosis and treatment. Nursing is holistic care, the whole body. And that's why as CNAs, because we're nursing assistants. We're nursing assistants. So this is where we work, is understanding that all of the body is one organism. And if we have somebody there for diabetes, we're also going to be concerned about the rest of these things as well. Good? Medicine is dedicated to finding what's wrong and fixing that thing. So diagnosis and treatment. Okay, finding what's wrong and fixing that thing. So, and I'll give you an example of life without nurses. Let's say you have a gallbladder issue. You go into the hospital. They say, oh, your gallbladder needs to come out. They get the surgeon. You have surgery. The gallbladder comes out. And if nursing is not in the house, if there's no nursing, as far as medicine's concerned, you're done. They don't care whether you have to pee. They don't care about brushing your teeth. They don't care about you eating. As far as medicine's concerned, you came in with a gallbladder problem. We took gallbladder out. We're done. Thank you very much. Here's your bill. We need nursing to make sure that we're fed and bathed and groomed and, all these other things are taken care of, and to monitor the lab work to make sure that gallbladder surgery didn't push something out of whack. To make sure that all the body systems are working well, that you're not having any side effects from the anesthesia that they use to put you under. So there's nursing is more big picture. Make sense? So as a CNA, we need to know that there's lots of body systems. They each do their own job. And as a CNA, we're not going to ignore any of them. We have to know they all exist. Now, as we age, we've talked a little bit about this, the aging process. We know that as we age, that fat layer between our skin and muscle gets decreased, and that affects our ability to sense temperature. It affects protection. It affects our ability to maintain body temperature. It does a lot of things. But that's not the only body system that's affected by aging. Every body system is going to be affected by aging. And that's what we are going to focus on, because if we don't know what's normal for aging, we'll never be able to see abnormal. Anybody watch the game show yesterday? Anybody watch the game show yesterday? I had a question in there specific to this topic. Okay. Knowing what to report. And the question had to do with you're caring for a patient. You've been caring for a patient for a while, and they suddenly become confused and don't know who you are. So what is the first thing that you would do? And a lot of people put continue care as normal, because in a lot of people's minds, confusion is normal for the elderly. But there was a word in there that should have triggered you, and that word is suddenly. Aging is a long-term process. Nothing sudden about it. Nothing sudden. So if your patient sudden anything, that's not normal. Ever. Ever. If they are different now than they were this morning, that has to be reported. That is not the aging process. So as we go through these, I need you to understand that this is slow, gradual, long-term effects of aging. Anything sudden has to be reported. So if we suddenly have a diminished sense, like suddenly you can't see, suddenly you can't hear, suddenly you're not smelling anything, suddenly you stop eating because you can't taste a thing. Those are all red flags that say, hey, something is up. Good? Makes sense? But a slow decrease in the senses, very common for aging. So as we get into our older years, we may not be able to see as well. So we want to make sure the lights are bright so they can see. We may get a slow decrease in hearing, which means that you may have to repeat yourself a couple times, and make sure you're standing facing somebody when you're talking. If you have diminished hearing and I turn around and I'm kind of looking at the TV, you would not know that I'm talking to you. There's no clues there that I'm talking to you. When I look at you and I face you, you know I'm talking to you. Make sense? So diminished senses are actually a really big deal when we're communicating with elderly populations, because they probably will have some decrease in eyesight, some decrease in hearing. They're probably not going to be able to feel as well either. Their peripheral nerves inputs get diminished. So if you have a rug on the floor, like a throw rug, there's not much height difference. I mean, you're talking about maybe that much difference, right? When you put a rug on the floor, just a little bit of a difference. You can feel it though with your feet. Now, if you have diminished peripheral nerve sensation, you don't feel as well. And we're going to talk about why in a little while. But walking on that, just that little height difference can cause you to lose your balance. Make sense? Okay, so diminished sense is very common as we get older. So we have to take these things into account when we're talking about communication and safety and things like that. Decreased coordination. I am starting to suffer from this, guys. I'm getting older. I am getting older. And my coordination is not what it used to be. I used to have an incredible sense of balance. I used to be able to walk on, very thin things. I had an incredible sense of balance. I can't walk on the flat ground anymore. My husband is constantly like, there's a step, step down, because I have fallen a couple of times because my coordination is just not what it used to be. Right? So aging can affect this. Now, sudden lack of coordination, is that normal? No, sudden lack of coordination gets reported. Absolutely. Slower reflexes. If I start to fall, I'm probably not going to catch myself. Yeah, I'm just not. Slower reflexes. Memory impairment. Now, I want to talk about memory impairment. This is not memory impairment. I don't know who you are. This is memory impairment. Did we have lunch already? Short-term memory is kind of hit or miss in the elderly. And let me explain why. Let's say that I invented, we'll use this guy. Let's say I invented this guy. He's cute, isn't he? This is a tuberculosis bacilli. Let's say that good morning. Let's say I invented this guy and I want to sell him. And in order to sell him, I have to have him produced. So I go tour a couple of factories. And the first factory I tour is brand new, state of the art. Everything is computerized, high quality items that get produced. I like that factory. The second factory I go look at is about 80 years old. Half of the stuff doesn't work. The gears are rusty. The springs are missing. And the stuff that it does produce, it can be hit and miss. Sometimes it gives me good stuff and sometimes it doesn't. Right? Which factory do you think I want? The first one. Why? Better quality, more efficient, more consistent, right? Okay. So we need to understand that our brain is a memory making factory. That's what it does. Your brain is a factory and it makes memories. That is the thingamajig that your brain makes. Memories. Now, when your brain, your memory factory is brand new, it's going to create some really good quality memories because everything is working in tip-top shape. But that factory ages with you. So when that factory becomes 70, 80, 90 years old, it is now the rusty gear, missing spring, broken down factory. What kind of memories do you think that factory is going to make? Yeah, spotty. Sometimes they might be good. Sometimes maybe not so much. And sometimes they may not be working at all today. We have to understand that this is normal for aging. So as we get older and our brain factory gets older, it may not create memories at any specific time. So that brain may not know, did we have lunch already? But it can remember the shoes it wore to a piano recital when we were 12. That memory is going to stick around because it was made in a good factory. It is a good quality memory that is going to stand the test of time. So as we age, short-term memory impairment becomes pretty common. Longer-term memory impairment, that's disease process. Something is going in and wiping out those memories. Good? So if a patient asks you, did we have lunch today? You don't have to be mean to them. Of course we had lunch today. We just got back from lunch. You had a turkey sandwich. Don't you remember this? Is that going to make their memory-making factory perform any better? If I stood in front of those rusty gears and I yelled at them, is that going to fix the rusty gears? And yet a lot of CNAs make this mistake. We have to be careful here. This is normal. Now, if you have a patient that's with it, and has nothing wrong with this, they remember stuff and then today they can't remember, Is that a problem? Is that normal aging? What do we do with that information? Report it to the nurse. Good? Make sense? Decreased concentration, very common. I'm actually starting to suffer from this. Guys, I do a lot of work. I sit in front, and I'm not exaggerating here. I'm not trying to pat myself on the back or anything like this, but I sit in front of my computer 12 to 14 hours a day, 7 days a week. I am not kidding. I am not exaggerating. I hardly take any time off. And I create a lot of content. Every one of these slides that you see, I'm going to show you 1,400 slides in the course of this course. 1,400. Today we have, I don't know, 170 something to go through. Now, everything that you see on here, I drew. This, I created. All of this, I created. The book that you are reading, I created. All the videos you see online, I created. I edit them as well. I do all of our own sound work. Guys, I am constantly going, constantly. But this is becoming a problem for me because I'm sitting at my desk 12 to 14 hours a day, and occasionally I'll look up and find myself on Facebook and wonder, how did I get there? I was working. What happened here? My brain wandered and I didn't realize it until I'm got something in my hand and I'm looking at it. It's like, wait, I'm supposed to be working. This is a normal sign of aging. So if we've got a patient and we're trying to get that patient dressed and we tell them, okay, put your pants and your shirt on. I'll be back in a minute to help you with your socks and shoes. And we go out and we come back and the patient is sitting in the chair staring at the birds out the window and they are not dressed. Should we yell at them? No, because they probably have age-related concentration issues. Good. They're not being difficult. They're not giving you a hard time. Okay? When you get out there and you start working, you're going to understand why we're having these conversations. You're going to see. Right now, you're like, who would yell at a patient for that? That is ridiculous. Nobody would do that. But when you get out there and you start working, you're going to see why I have to say these things. Because I do not want you to be one of those. And there's a whole lot more of those out there than there should be. Okay? So I know you can roll your eyes. I get it. I understand. But I have to be the one person that says that is not right for you to know that you don't follow the crowd. Okay? Super sad. Is the body system one of the topics for LPNs? Yes. Yes, Helen. Not to the extent of the RN, because there are no prereqs to get into LPN program. So to get into the RN program, you got to have that year of anatomy and physiology before you even get into nursing, right? LPN, everything is all in one. LPN is a 12-month version of nursing school, but it's the first year of nursing school. It's kind of a step-up version of what we learn. So multiply what we learned by 12. We're here for a month. Multiply what we learned by 12. You're going to go that deep into it. Okay, good. Now RN, multiply what we learn by 36.
So what is the difference between the LPN and like what do they do different?
Okay, so an RN is the only one that can create a care plan. LPNs cannot do that. So they don't diagnose, that's the medical team. But the RNs identify issues, real problems and potential problems, and come up with a plan to manage the real problems and prevent the potentials. So the best way for me to describe this, and every LPN out there is going to send me hate mail over this. Now, understand that I was an LPN before I went to RN, and you don't know what you don't know. Keep that in mind. I was the LPN that said, I do the same job as an RN. Why don't I get paid like an RN? And it wasn't until I became an RN and I realized the magnitude of information that the RN has to draw from is way different than you can't see thinking. That's the problem. You can't see the thinking process. But LPNs are the doing nurse. They do. RNs are the planning nurse. They plan. Now, RNs do as well, but they have to have a much bigger amount of resources to draw from to do the planning. Because remember, I'm looking for real problems and potential problems. Our LPNs are dealing with the real problems, not the potential. And remember, potential, that's all thinking stuff. That's not something you can see. So that's the big difference.
So the LPN, you feel like is more hands-on?
Way more hands-on. Way more hands-on. Yep. Good.
Mm-hmm.
So that's why LPNs have to work under an RN, because the RN plans the care. The LPN can do the nursing part of the care, and you guys do the patient care part of the care. But it all has to be planned out by that RN. Good? Now, that doesn't diminish any role. I want to make that clear. It takes all of us to make the system work. Because if I am so busy doing, then I don't have the time to plan. Good? So it's a team effort. One is not any better than the other. If any of them are absent, it's going to affect the whole system. They're all important. It's just different levels, different depths. All right, so cardiovascular body system. Again, this is going to be a slow, gradual decline based on aging, because your heart is a factory, just like your brain, it's going to age with the body. So as we get older, we see decreased endurance. We tire out easier. We get higher blood pressures because the inside of our arteries are a little thicker. The arteries themselves are a little stiffer. Prolonged bleeding because our platelets, our bone marrow isn't producing good quality platelets. So we end up with prolonged bleeding and fragile vein walls. So bruising becomes very, very common. Now, for me, you can actually see, I ran into a door here and my puppy got me here. But normally I have, like all kinds of like stuff on my arms, because the vein walls, as they get more fragile, any little tiny tap can cause them to leak blood under the skin, and that's a bruise. Very common. So we have to be super gentle with our elderly patients. Respiratory system. This is your lungs and breathing pathways. We get decreased lung volume. We don't breathe as deep as we used to. Now, that can lead to a lot of really big problems later on, because if we aren't breathing deep, the stuff in the bottom of our lungs never moves. It becomes stale. And all the secretions in there tend to thicken and harden. And now we've got less lung to work with. But it also can predispose us to pneumonia, which is fluid in the lungs. Less endurance, especially on exertion. They used to be able to walk to the dining room just fine. Now, when they walk to the dining room, they're way too tired to eat. That's something we probably should be reporting to the nurse, because if the patient isn't eating today because they're tired, what do you think is going to happen to tomorrow's energy levels? Hungry, yes, but what about their energy? We have to have, right, we're going to have low energy. That's right. So is that something we should be reporting to the nurse?
Yes.
Sure. Shortness of breath can happen as well. Endocrine system definitely gets affected by the aging process. We have decreased hormone production, and we all know about this, but it's more than just the sexual hormones. We just talked about hormones a little while ago. We have insulin and pituitary and thyroid and ACTH and adrenaline and all of these different types of hormones. And all of those are going to be diminished. So it's this controls every body process we have. So this is kind of that slow, gradual slowing down. They may not be able to eat late at night, or what they consider late at night. You might consider 6 o'clock early. They consider 6 o'clock for dinner late because their digestion slows down and they can't digest it before they go lay down. Then they end up with acid reflux and a whole issue. Sleep disruptions, very common, very common. And I'm going to tell you that this right here is essential for you to understand, especially if you're working the night shift. Because this right here is the number one reason for using side rails in a clinical setting. CNAs will try their best to justify side rails with their elderly patients. Well, she won't stay in bed, and I don't want her wandering around at 3 a.m. She might fall and get hurt. They need less sleep. They are less physically active. They're less mentally active. They have sleep disruptions, and they're probably going to be up at 3 a.m. Putting them in bed with the side rails up does not fix this. And yet we do that as CNAs. We think they should be on our sleep schedule. Try telling that to an infant. You should sleep when I tell you to. Doesn't do anything. Doesn't do anything for the elderly either. You should sleep when I tell you to. I mean, that's just ludicrous. And yet CNAs put patients in the bed and put the side rails up because it's 3 a.m. and you should not be out of bed. It is sleeping time. This is like telling insulin, you should work better. You're not going to get anywhere with that other than you're increasing the risk of injury to your patient. Make sense? Decreased bone density. So if they do fall, likely to break something. Reduced metabolic rate. They're not going to process food as effectively. Bladder. This is the number one change that you will notice. They cannot hold it as long. Their bladder cannot hold as much. So bathroom breaks are a big part of what CNAs do. And you might, as a young person, have a little thought, maybe I should go to the bathroom. And you can ignore that thought for a couple of hours. And then eventually you're like, oh yeah, I probably need to go. And then you go to the bathroom and everything works just fine because you're young. Things work. But as we age, that bladder is not going to hold as much. So you're going to fill up a lot quicker. You also aren't going to be able to hold it as long. So when I say I have to go to the bathroom, oh, I got to go to the bathroom. I don't have time to wait for you. This is important. This is about half of what you're going to do is help patients with toileting. About half of what you are going to do. Incomplete emptying, very, very common. And decreased muscle tone and controlling the stream. So it may just kind of dribble instead of coming out as a stream. But I want to talk about this specific thing today. I told you I'm plugged into a ton of groups online, right? So this came up this morning. And my husband had to listen to me have something to say over this. So I'm going to read this to you. This is a post, okay? And I'm going to kind of try to shorten it because it's a long post. I mean, it's a long post. So let me try to shorten this. But basically, we've got an elderly patient who's on Lasix. Lasix is a diuretic, which is a medication that's designed to help the patient pee out excess fluid. So a diuretic means we're trying to move fluid through, so they're going to have to pee a lot, okay? This patient has both legs covers and sores. I mean, just very difficult to get up. She's overweight. She has a bedside commode, which is a toilet right beside the bed, toilet-like thing. Okay, now this patient has urinary incontinence as well. So she has trouble, you know, with all of these issues, she has trouble getting up and making it to the bathroom or the toilet quick enough. So she ends up wetting, you know, it's not that far, but she ends up wetting. And the patient asked for something called a PureWick. Now, a PureWick, if you look in your book on page 155, I have a lesson in your book about automated collection devices. And a PureWick is something we use on women. And it's just this little cotton tube that we put in the area next to the urethra. And as urine comes out, it's attached to a vacuum and it pulls the urine away from the skin. So it does sound like a vacuum. So it keeps the patient's skin from being wet all the time. And the patient asked for a PureWick. And the CNA got the PureWick system and put it on the patient because the patient requested it. And she said, I got in trouble for applying the PureWick. She stated that our unit manager says we are never to use any PureWick on any patient that is able to ambulate at all. So I asked her, but isn't that the patient's right to choose? And she responds with, it shouldn't even be an option. So one of the comments here, and this is what I really wanted to hone in on. It says nurses, this is a comment on that. Nurses can place an order for a PureWick where I work. As CNAs, we cannot initiate one, but I've always been told I can reapply one if needed. You're right. This patient needed it. And if she asked you, you were right to do it. I think the nurse is mad because she didn't specifically ask you to, which is kind of a power trip.
Go ask the nurse before she did it.
Was this a power trip? What do you guys think? Do you think the nurse was on a power trip telling the CNA that she cannot initiate care? What is the role of a CNA?
Go to the nurse. Follow the care plan.
Say it loud.
Follow the care plan.
Follow the care plan. The PureWick was not on the care plan. What is the role of a CNA?
Follow the care plan.
If the PureWick was not on the CNA, is the CNA allowed to initiate care?
No.
Is that the role of the CNA? Whose role is it to initiate care?
The nurse.
The nurse. Was the nurse on a power trip?
Yes. No.
That is their role. Do you guys see that? Now, this sounds reasonable. The patient can't get to the toilet. The patient's wetting themselves. The patient asks for it. I put it in. It sounds reasonable, doesn't it? It is completely against your scope of practice. That right there is enough to get that CNA in front of the Board of Nursing. Do you guys understand that? That is a violation of your scope of practice. Now, you guys were trying to justify it. You guys were trying to justify it. Do you see how easy you can fall into that? What is the role of the CNA? Follow the care plan and report all observations, period. Full stop. Does not go past that. So if you're trying to figure out, is this something I should do? What is the role of the CNA? Follow the care plan or report it to the nurse. There is no third option. There is no go get a PureWick and put it on the patient because they asked for it. That has never been anything that I've told you to do. Do you guys see that? I'm trying to keep your certifications safe. Because I'm going to tell you right now, if the Board of Nursing gets a hold of that, that CNA is going in front of the Board of Nursing. Not just their job, their entire certification for doing something the patient asked you to do. Now, I want to talk about this from a different standpoint. We talked in class on Monday that every single thing that is used on the patient has to be billed to the patient. So this CNA took it upon themselves to add something to the bill that was not on the care plan. Now, that patient can get that bill and say, hold up, I'm not paying for this. And the facility would have to eat that cost. Yeah. So there's a whole lot more to this system than you guys see. And this is why it's imperative that you understand that CNAs follow the care plan and observe and report. That's it. We don't initiate care. Good? Make sense? This patient's payment source, which is most likely a Medicare HMO, does not authorize the use of PureWigs. There's a lot to this situation that you don't know as the CNA. Good? Make sense? Okay, super important that we understand this because it's really easy to try to justify it. Really easy to try to justify it. Integumentary, we've talked about this system and how it changes with aging. We're going to talk a little bit more about it today as well. We get thinner, drier skin, brittle nails. We've talked about that with hand and nail care. Decrease in subcutaneous fat. We talked about that with washing rules. We also get a change in hair color. Yeah, you can see that right here. I'm getting more silver in my gold. Decreased hair production and darker pigmented age spots. And this can affect your patient's self-image as well. A lot of patients, they look in the mirror and they don't see the young person that they feel inside them reflected in the surface. Because you might be 80, but you still feel inside like you do now. Okay? Your emotional self ages at a different rate than your physical self. So if we've got a patient that is focused on how they look, we might want to take a little extra time and brush their hair and, make sure that they're presented well because that affects their self-image. Reproductive, this does get impacted with age. We get hot flashes and night sweats as we age, decreased moisture production, erectile dysfunction, external skin can become thinner and drier, and we get decreased fertility as well. Although this does impact females a little more than males, but decreased fertility across the board is pretty common with aging. This is probably the one your patient is going to be most obsessed with, though, because we eat every day, and patients tend to get fuller quicker. They tend to, the things that they used to enjoy eating, they may not be able to tolerate, and that can be very distressing. How many of you guys like pizza? How many guys like pizza? Oh, I like pizza. Yeah, and as you age, you may not have the ability to enjoy your pizza anymore. And how distressing would that be if you really like pizza or hot wings or jalapeno poppers or insert your favorite food here? My best friend took care of her grandmother, and her grandma couldn't tolerate garlic. Now, she had used garlic in her cooking forever. My best friend uses garlic in her cooking. So my best friend had to figure out a whole new way of cooking because her grandmother, who was living with her, could not tolerate garlic anymore. And you don't realize just how much you use something until you can't use it anymore. But this is very, very common. We get constipation quite often. Now, let me explain this. because this is what's going to drive what's on your care plan in a very big way. So, something that most people don't understand, all of these small intestine loops are smooth muscle. They don't contract on their own. So food has to have external muscle contraction to move through your digestive system. Now, what that means is all of your tummy muscles here, the ones outside that we can see, those muscles, when you sit up, stand, talk, walk, turn over, when you move, these muscles contract and release. And that's what moves food through your digestive system and into your large intestine to be sent away. So if we have an elderly patient that has decreased endurance, decreased coordination, decreased energy, and they're sitting all day long and they're not doing anything, or we put them in bed and put the side rails up and say, stay, because we don't want to deal with them. What is happening to the food inside these small intestines if we aren't moving our abdominal muscles? It just sits there. And as it sits there, it hardens. And as it hardens, we get constipation. This is your fault. Because it's easier to leave the patient in bed than get them up into the chair. It's easier to put them on a bedside commode than it is to help them walk to the bathroom. It's quicker for us. So a lot of times the shortcuts that we take, thinking that it has no impact on the patient, has a very big impact on the patient. In fact, it's actually called fecal impaction. Okay, so a lot of the things that you see on the care plan, you may not understand why they're there. Patient out of bed and into a chair twice a day. You may not understand why that's in the care plan. Is it your job to understand? What's our job? Follow the care plan. Good? Make sense? All right, we can also get decreased hunger and thirst reflexes. This right here, probably the worst part. This is horrible. When you get thirsty, you take a drink. You get thirsty. You know you're thirsty. I'm thirsty right now. I'm going to take a drink. Right? I recognize the fact that I have cotton mouth and I'm going to take care of it. Unfortunately, as our reflexes diminish, this diminishes. Your patient won't realize that they're thirsty. They don't take a drink because they don't realize they're thirsty. What do you think that leads to? Dehydration, which will in turn affect this. Do you guys see how that all goes together? So every time you walk into a patient's room, if they're over 60, you should be offering them a drink unless they have a reason not to, which would be on the care plan. So, hey, Miss Mary, did you drink yet? Take a drink for me. Hey, Miss Mary, take a drink. Hey, Miss Mary.
So we're allowed to.
Oh, we're going to encourage the heck out of this. Every time you see a patient, unless they're on fluid restriction, you should be reminding them to drink. That's how we prevent dehydration in the elderly. That's a very, very common reason for hospitalization is dehydration in the elderly. Very common reason for hospitalization. Musculoskeletal system. We get decreased bone density. And remember, we had this with the hormones. We also have it affecting the musculoskeletal system. You have to have calcium in your bloodstream for your heart to beat regularly. Your heart's rhythm depends on calcium. If you don't have enough calcium because you have decreased hunger reflexes and you're not eating very well, and maybe you don't tolerate cheese or yogurt or milk anymore, if you have decreased calcium intake, your heart could end up in an irregular rhythm. So in order to prevent that, the heart goes and looks for calcium. Where do you think we store calcium? In our bones. So we have something called osteoclasts, which are little miners. They got these little hard hats, these little pickaxes, and they go over to the bones and they just kind of chip out a little calcium and they put it into the bloodstream so the heart beats right. What does that do to our bones if we're constantly mining the calcium out of them? They become very porous, very brittle. So what happens if this patient falls? Yeah, they're probably going to break something. Yeah. We get reduction of muscle mass, muscle tone, and muscle elasticity. So Jake and I went to lunch on Monday. We went to the Outback. I sat in a booth, and my legs are short, so I was dangling, right? I go to get up, and he says, you need some help because it's, you got to step down. So I go to get up, and I had to kind of stand there a minute and let all the hydraulics kick in so I can start walking again. And it's because I'm aging, right? I have decreased strength, decreased endurance, decreased muscle mass and tone. I got to get back in the pool and start doing my exercises again, which will help. We have decreased strength, inflammation of the joints. Man, I'm getting this. Instability and coordination impairments. This is a mess. We need to be walking with our older patients because chances are they got a lot of stuff falls. So watch your patients closely. Lymphatic system. This is kind of the hidden system, the unknown system. Most people don't know much about your lymph system, but think of it as the recycling center of the body. When you get fluid that's in the wrong place, your lymph system gets it out of the wrong place, filters it, gets all the bad stuff out and puts it back into circulation. It's the recycling center of the body. Unfortunately, it's not one center. It's a whole bunch of little tiny nodes all over the body, everywhere. Your lymph vessels mirror your arteries and veins. This thing is like a whole body system, but it has a lot to do with our immune response. So if we don't have good lymph workings, we're going to be at risk for infections. Good? Good. We can also hold fluid in our lower extremities because our lymph system is not working well. All right, so any questions on normal signs of aging, things that we should know about our patients as they age?
For the thing that you brought up about the nursing and the power trip, right? So yesterday when I was at work, I had a situation. My patients tend to get very aggravated, especially old crying women, due to how upset they get over anything. So she was getting so upset, and I was calming her down, and I look at her face, and she starts to turn purple, and her lips, the bottom of her face starts turning purple, and she's pointing at her heart, and she could not breathe. Oh. So in my situation, I have 1 to 17 patients. My med tech is out. You know exactly what I'm talking about. In memory care, they leave, and my walkie's dead, and I don't know what to do in that situation because I didn't know that she had a heart. I don't know what they call. They're on the heart. I didn't know she had that. Pacemaker? Yep, I didn't know she had that. I didn't know anything about this patient at all besides that she's an Italian woman with dementia that is angry and was a smoker, so she has the high breathing thing. So that's what I know about her. I'm screaming for help. They come in. I asked them, I said, so what is the cause of this? Well, she has this, she has that. We did not have anything. There's not a book. There's not an explanation on any single patient. So when in the care plan, when I'm following it, because I'm a low grade of whatever they put in the book so they can hire people without having to use money. So in that situation, what am I supposed to do? Because I'm sitting there like this. What was I supposed to do? They said, did you give her orange juice? How in the hell would I know to give a woman with orange juice with a heart problem? If you're not going to tell us. We don't know any information about this patient.
Yeah, and no, I definitely would not recommend giving orange juice.
That's what they told me.
Yeah.
You gave her orange juice? I said, no, don't give her orange I'm giving her water. She's freaking out.
No, I definitely would not give her orange juice because I don't know. Again, we don't have any information about the patient, and we don't know if she's diabetic with with a high blood sugar. And you dump orange juice in there, that's just pure sugar. So that's and high blood sugar can make you very irrational, erratic, frustrated.
She was having a heart attack? No, they said that she was having a small cardiac arrest.
Well, that's a heart attack.
Yeah. So I'm like,
But did she,
No, they didn't get sent out.
okay, then she did not have a heart attack.
Yeah.
So if you can't diagnose a heart attack by symptoms.
Yeah, there's
You
like
have to
3
have,
nurses that came in and did all the stuff, and they didn't explain nothing to me.
Yeah.
They literally just walked out and was like, she's fine. Call her daughter and ask if they want her to get sent out or not. What am
yeah.
I supposed to do? If this happens this small over her getting upset about socks, what else is going to get her upset?
Yeah, and
Yeah.
you should not have been the one to call the family. That should have been the nurse's responsibility.
The med tech.
Yeah, there's a whole lot wrong in that scenario. So let me explain to you just a little bit. I don't really want to get in the weeds here, but you handled that well. You got to get help. You just got to get help. So let me explain to you about an ALF, because a lot of people don't really understand what an ALF is. So I'm going to lead you there. So just stay with me for a minute, okay? You guys all live in a place, right? Apartment, a house. You live somewhere and you live pretty independently. You don't need anybody to help you, right? You may live with other people, roommates or family or whatever, but you get up, you brush your own teeth, you brush your own hair, you get dressed. You're independent. You do your thing, and that works until it doesn't. And when you start to need help, the first thing that you probably start to get help with is not your person. It's what your person does. So you might get some help with a house cleaner, so you don't have to expend that kind of energy. You might get some help with a lawn person so that you don't have to expend that kind of energy. You might get some help with somebody doing your shopping so you don't have to expend that kind of energy, right? So we start with getting help, not for our person, but for what we do. Make sense? As we age, we start to get some help. Eventually, we may need some help with our person. So we hire somebody to come in a couple hours a day, help us with bathing and dressing and grooming and all that kind of stuff. Make me a sandwich for lunch before you go, please. Right? But at some point, that all becomes expensive. When we're paying somebody to clean our house, mow our yard, do our errands for us, and help us with our daily tasks, that gets expensive. So at that point, people start to consider an assisted living facility. Now, assisted living facility is not anything medical. Not. An assisted living facility is an apartment. That's what you're renting, an apartment that provides meals, housekeeping, outside maintenance, and somebody to help you come in and do the bathing, dressing, grooming, make me a sandwich before you leave. Okay? That's what an assisted living is. It's the same thing you had at home, nothing medical, but you're doing it in a place with other people like you. Good? Now, in most assisted living facilities, they also have a unit for people that are confused, people with dementia, people that aren't safe at home. Now, these people might be able to brush their own teeth and their hair and get dressed. They might still be able to do the person stuff, but they're confused, so there's a safety aspect there. But they might also need help with the person stuff. Either way, we're going to help them. We're going to put them in a place, and this place is going to have a locked door to keep them safe, keep them from wandering off on their own. But notice there's nothing medical going on here. There's nothing medical. Brushing teeth is not medical. Bathing is not medical. Do you guys see that? An assisted living is not medical. It's apartment living with personal care. Personal care is not medical. How many of you guys have a best friend? If your best friend phoned you up tomorrow and said, oh my gosh, you're not going to believe the night I had. I need you to come over here and help me get dressed because I picked up a porcupine. It was a wild night. Can you come help me get dressed? You'd go over and help him get dressed. It's what you do as a best friend. Did you need to have a certification to help somebody get dressed? If they say, can you help me brush my teeth? Do you need a certification to help them brush their teeth? No, this is not medical care. That's why they can hire people without their CNA. It is not, it's personal care. It's stuff you could do on your neighbor. Does that make sense? Now, the problem with that is because it's not medical care, there's no care plan. Because it's not medical care. There's no care plan. So if you walked into an apartment and somebody was complaining of chest pain, what would you do?
Call 911.
Absolutely. Absolutely. So when we start to realize that ALF is not medical care, we don't respond to medical issues the same way we would in a medical facility. So what I would suggest for your specific situation is you need to go to your policy and procedure book, not the med tech, not the supervisor, because I guarantee you they have not read that policy and procedure book. And you need to look up, what do I do when a patient complains of chest pain or indicates chest pain? What are the actions that I'm responsible for taking? And it's probably going to be, number one, contact the med tech and the floor supervisor. That's probably going to be your first thing. It's not going to tell you to give them orange juice. You are absolutely right in the way that you responded.
Yeah, they told me that I was right, but it's just to the point, it's like, how do you expect me to give full 100% care and
If you don't know at
if
all.
I don't know what's going on
Right.
with her, because her emotions were so high that I was literally just trying to calm her down, and it was too late for her to do it, and she just started freaking out and she turned purple on me. So I had to sit her down, and that's when I called for help. But it's like, what am I supposed to do in those situations and if I'm by myself?
Right.
Like, you got me screaming like a bloody murderer in the hallway, and I'm like, I don't even scream at all, so I'm like weirded out by myself hearing my voice that loud. So I'm
Yeah.
like screaming, and they're all coming running, and it's like I'm sitting there, and they leave with no explanation. Just call her family, and they leave. What do you mean?
Call 911.
If it's that easy, she's gonna do it again. She's gonna do it again. She gets mad all the time.
Right. And again, you're going to have to go by your facility policy on that particular situation. If I were in charge, if it were me as the director of residents at that facility, I would not have unlicensed people making that determination. You can't just throw away, yeah, she had a small cardiac arrest. No, it doesn't work like that. We have to have troponin levels. We have to have EKGs. We have to have a heart cath done. We can't just look at somebody, take their blood pressure and say, oh, you just had a small heart attack. It does not work like that. I'm also concerned about her blood sugar levels. Did anybody check those? I mean, there's a lot of steps here that it sounds to me were probably overlooked. I don't know that this person got the type of care that they needed in that situation. So I would go by your facility policy, and your facility policy probably instructs somebody at that facility to call 911 for all chest pain complaints. I would strongly imagine that somewhere in that policy and procedure under chest pain, they're instructed to call 911, which they did not do because it's not their call to make to diagnose a small cardiac arrest and walk out of the room.
Yeah.
That's not their call.
They left me with her all day, so she didn't leave my side. It was like she was on the leash with me. I literally was holding her hand all the whole day. I couldn't, because I was like, what am I supposed to do with you? Like, you get mad about everything. She hears the noise, she's mad. It's just an old Italian woman.
Can she talk?
They
Yeah,
get
she
very
can,
mad.
yeah, she can talk.
They get very mad.
Well, be careful about generalizing that, because I do, in my family, I actually have some old Italian women that aren't like that. So be careful about the cultural. Yeah, well, that might have something to do with it, but just be careful about the cultural blanket statements. Yeah, certainly getting her involved in something? Does she like puzzles? Does she? One of the things that I used to do with my dementia patients, especially the women, when I needed to buy some time, every dementia unit has some magazines, like Good Housekeeping magazines, and Oprah magazines or whatever. Every single one of those magazines has a Snuggle fabric softener ad in it. Like, their advertising budget is insane. And I would hand a magazine to an older dementia person and say, hey, there's a teddy bear in here somewhere. I don't have time. Can you find the teddy bear for me? Now, flipping through a magazine is a very culturally relevant activity for older women. It was something that they're very familiar with. It's a long-term, deep-seated memory. Remember, those are the ones that kind of stick around. And if you ask, teddy bears are non-threatening. So it's usually a calming activity for them because it brings back times of, kind of free time. Yeah, things that they used to do, right? So it can actually have a calming effect. Most of those also had like perfume samples, so they're very calming smelling as well. And a lot of times that will give you a little bit of time, just flip through and find that teddy bear for me. And it gives me a few minutes to take care of the things that I need to take care of. So that can be a really, really good tool to have in your toolbox to buy yourself a little bit of time when you need to. But that patient, honestly, probably should have been evaluated by somebody other than the med tech. That's just, this is why my mother will not end up in a facility. That's scary, scary. All right, so quick review. Oh my goodness, we are way late on time. All right, quick review here. A pulse is a measurement of how many times a heartbeat over 1 minute. We're going to support the arm. We're going to follow the care plan on how long we're going to count. Normal is 60 to 100. We'll use our fingertips, not the flat area of our fingers. Radial pulse is located at the thumb side of the wrist, up near the bone at the bendy part. And this is a documentation skill. We learned how to dress a resident with a weak arm. So we're going to ask about clothing choices. We'll get the clothing first before we undress them. Lift from below. Support all joints when lifting. We're going to undress the strong arm first and dress the weak arm first. Don't overextend or force movement. Adjust the clothing for neatness and appearance. Put your dirty items in the hamper and put the call light in the stronger hand. We learn hand and nail care. This is going to be important to us in just a few minutes as well. We're going to support the wrist and arm at all times as we move it. We soak the hand in water. We wash, rinse, and dry. When the hand is out of the water, we have it on a towel. We're going to clean under the nails with an orange stick, the slanted end, not the pointy end, wiping it off in between nails, and we'll file the nails in one direction. We'll apply lotion last, warming it in our hands, and then wiping off the excess. We learn how to make an occupied bed. The patient should always be in the middle of the bed, whether it's on their back or on their side, doesn't matter. They're always in the middle of the bed. Clean rolls toward me, dirty rolls away. So you roll the dirty sheet toward the patient, tuck it under them. Roll the clean sheet towards you, tuck it in under the dirty. Go around to the other side, do the same thing all over again. Put the top sheet on, make hospital corners, loosen it over the toes, change out that pillowcase, but do it quickly so we limit the amount of time they're on the bed without the pillow. We learned range of motion. We lift extremities from below with a flat palm, 2 points of support near the joints. Don't overextend or force movement. Flexion, extension is up, down. Abduction, adduction is side to side. Rotation is around. We follow the care plan. All right, any questions on any of that? Let's learn a new skill. Page 138. If you look down the side here, you can see all of the principles that are involved in this skill. They're all spelled out for you here. This is kind of the short version of the skill. I have a video for this. And then right here, you can see the test-specific information. Somebody with your level of experience should be able to do this skill in 8 minutes or less. Guys, we're turning somebody on their side. They give you 8 minutes to do that. Way more time than you need. This is going to be done on another live testing student, so you might be the patient for this. That person will be positioned in bed. Charting is not required for this particular skill. You can see the step-by-step instructions here on page 139. Care plan at the top, supplies at the bottom. So this is our care plan. Position the resident on his left side. Remember, the care plan may say right for the test, may say left. We're going to follow the care plan. Patient requires support to remain on his side and is unable to assist with turning. Remember, we follow the care plan, the whole care plan, and? Okay, do not make this patient immobile. Does it say anywhere in here they're immobile? No, it just says that they cannot assist with turning. Don't turn this into a 90-year-old invalid who is paralyzed. That is not this patient. This patient just can't assist with turning. So imagine somebody who just had abdominal surgery where the whole abdomen was cut open and they've got some little strips that just tape it back together. That person cannot flip over on their side because you have to have your tummy muscles to be able to do that, right? But they can scoot towards you. Don't make something that's not there. Does that make sense? So for the test, you can ask the patient, hey, can you scoot toward me? It says they're unable to assist with turning. It doesn't say they can't move. Good? Make sense? All right, so there's nothing new to learn here. We've learned all of the principles. Remember scoot and roll? Patient has to be in the middle of the bed, so we scoot them toward us and then roll them away. Remember that? Right? Remember linen rules? We don't hold linens against our uniform. You remember privacy blanket? We're going to use one anytime the patient's uncovered or undressed. We have to have a clean place to put our clean supplies, and we're going to evaluate if we need gloves for this patient. Every skill starts with an opening. Every opening starts with a knock. And we already know the closing. So the only thing that we have to learn for this skill is this. The steps specific to the skill itself. So let's talk about restraints just a little bit. We talked about this on the last class, but remember, just like a crib keeps a baby confined, side rails keep an adult confined, and it's not going to work. Just like that doesn't work, that kid will climb out. Half rails are not side rails. Anything at the top of the bed only still allows the patient to get out. They're okay. Once we put this one up, though, it becomes a side rail, and we cannot use side rails without a doctor's order. I do want to talk about immobile patients, though. I told you this patient is not immobile. It doesn't say they're immobile in the care plan. But I do want to talk a little bit about immobility. Even though it doesn't apply to this particular patient, we got to talk about it. When we have a patient who is classified as immobile, that means they cannot move on their own. So I want you to think about all the movement you do every day.
So like, that means like paralyzed completely, all limbs.
Maybe. Maybe they could be paralyzed. Sure. They could also be super, super, super weak. They also might be on some sort of a drip that keeps their body from moving. Okay, propofol or something along those lines. They also maybe had a stroke and they have weakness on one side. There's a lot of reasons. They could maybe have ALS, which is amyotrophic lateral sclerosis, or Lou Gehrig's disease. Think Stephen Hawking, something like that, where your muscles and your nerves are just no longer working together. Okay, there's a lot of reasons why somebody might be immobile. Paralyzed is one, but there are others as well. So I want you to think about all the things that you do that requires motion every day. If somebody is immobile, that means they can't do any of them. So if they can't do any of them, that means we're going to have to do all of them. So somebody who is immobile is going to require assistance for all ADLs. Remember activities of daily living? Things we do for ourselves every day? Someone who is immobile will need assistance with all ADLs. Their care plan is going to be 6 feet long because we're doing it all. And then some. You guys get thirsty. What do you do when you get thirsty? Take a drink. Sure. If we have somebody who's immobile, can they take a drink? Probably not. If somebody is too immobile, they may not even be able to eat on their own. They may have a feeding tube. So if we have somebody who can't take a drink, that means we have to keep their mouth moist, right? Because liquid isn't going to do it. They can't take a drink. So we're going to keep their mouth moist. So that would be mouth care every 2 hours around the clock. So immobile patients need assistance with all ADLs plus some things that you may not even think about that would be on the care plan. A patient that cannot move on their own won't be able to do anything for themselves. Keep that in mind. That is what immobile means. But immobility has an effect on every single one of those body systems that we just reviewed. Every one of them. We're going to slow down digestion, and that's going to put us at risk for constipation. We talked about that. It's going to reduce lung volume. We talked about that. Remember, all the secretions can pool at the bottom. If your patient's laying down, the bottom is now the back side of the lungs. It can decrease bone density because if we're not moving, our bones aren't going to be as strong. We still need calcium, so we're going to go mine that calcium out of the bones. It can cause muscle atrophy, which is a shrinking of the muscles because we don't use them. Decreased immune response. So your patient's going to be even more at risk for whatever you bring them. And affects cognitive function. So they're not going to be as sharp as they might have been. Because unfortunately, we require activity to push blood to our brain to make those higher processes work more efficiently. But one of the biggest organs that's affected by immobility is the skin. And I want to show you how and why. We're going to do an experiment together so that you can understand why this skill is so important. Okay, so I want you to play along with me. I want you to sit on one of your hands for the next 2 minutes. Now, I'll tell you when to take it out. You'll want to take it out beforehand. Please don't. Sit on one of your hands. Just put one of your hands underneath your leg or your bottom. Now, this is going to take me about 2 minutes to explain. So in your body, you've got a lot of bones. When you're laying down, those bones are going to press down. Gravity. We have gravity on planet Earth. Gravity pulls heavy stuff down. So all the bones in your body are being pulled down, and that's going to compress your muscles, your nerves, your blood vessels, and your skin. So you can see here, we have that bone that's pressing down, and it's pressing all of these layers. But you can see here the blood vessels, they're actually going to get crimped. Now, what do you think happens when we don't get good blood supply to an area? Okay, it's going to go numb, sure. And that's because of pressure. But eventually, if we squish those blood vessels closed and we don't have any blood supply to the area, that tissue can die. Dead. Now, we're good in healthcare. We can fix a lot of things, but we can't fix dead. And that becomes a real issue here. So we don't want anything that's going to close off those blood vessels for a long period of time that could kill that tissue. Now, one of the things that can affect this are wrinkles. So you see the wrinkles here in this sheet? Those wrinkles are going to press up as the bone is pressing down, and those blood vessels that are trapped in the middle, closed. Now, this patient's at risk for cellular death in the area. That's bad. Now, it doesn't take a whole lot of time for this to happen either. I'm going to show you that in just a second. So when we have skin and muscle caught between the pressure from the bottom and the bones from the top, it gets squished. And that can cause these tissues to start to separate. So go ahead and pull your hand out and take a quick look at it. I want you to look close at it. Do you have any color changes? You guys see color changes? How many of you guys can see the actual pattern on your skin from your clothes or the chair? Can you see the actual pattern?
The blood area to come back though.
Yep. So you're healthy. Your blood comes right back. And that fades. How long was your hand under you? 2 minutes. And you already have imprinting in 2 minutes. What do you think would happen if we left your hand there for 24 hours without moving it? If you got imprinting in 2 minutes, whatever caused that imprinting, that area of pressure is going to go deeper and deeper and deeper and deeper into your skin. And over time, that can actually cause, if it gets deep enough, it can cause your skin to separate at that point. We call that a pressure sore or a bed sore. A pressure sore is formed because the skin and blood vessels and muscle get trapped between a surface and the bone and compressed for a significant amount of time. Now, you guys actually feel this all the time. You just don't realize you feel it. When you're sitting in these chairs, those chairs are hard. I know they're not very comfortable. I get it. I understand. And your body reacts to that by shifting, just like that, by shaking your leg, just like that, by leaning forward or back, just like that. You are constantly moving your position to relieve pressure in one area and shift it somewhere else. You do this without even being aware of it, and you do it at night too. When you go to sleep, you start out in one position, but you don't stay there. You stretch and move, you toss and turn, you reposition all night long, and that is because of this pressure dynamic. So what would happen if you can't do that yourself? That's right. That pressure won't be relieved. It's going to go deeper and deeper and deeper and deeper and eventually cut into the skin and cause a pressure sore. So if you can't move yourself, somebody else needs to move you. So we're going to talk about incontinence next week and the acidic nature of urine and how that can break down skin. So that just adds insult to injury. It does. All right, so this is why you change position frequently at night. You're trying to relieve those areas of increased pressure. That's why you toss and turn. If somebody can't do that on their own, we are going to change their position every 2 hours around the clock. Yes, that means you're waking them up at 2 a.m. to turn them over. It does. It means you're waking them up at 4 a.m. to turn them over. Yes, it does. And at 6, and at 8, and at 10, and at 12. We don't let them sleep through the night because we're being good guys. If you let this patient sleep through the night, do you know what's going to happen when you wake them up 8 hours later? They're going to have a pressure sore, a bed sore. That is absolutely correct. And they're not going to sleep for the next 3 years while we try to heal it. Bed sores can occur unbelievably fast if somebody cannot move on their own. Particularly the thinner they are, because there's less padding between their bones and the surface. So if you've got that little 80-pound teeny tiny bird of a woman who is not moving on her own in the bed, you need to be turning her, and you need to be religious about it. Religious about it. That patient, if that's my patient, that little teeny tiny 80-pound bird of a woman is going to have a care plan that tells you to turn them every hour around the clock. Now you're going to come to me and go, oh my gosh, Miss Patty, there's no way that I'm going to have time to move this patient every hour. And I'm going to say, I'm going to help you. But we can't change the care plan because we don't have time. That patient will end up with a bed sore. Make sense? Okay, good, good. Do you know where the most common place to develop a bed sore is? Anybody care to guess? Okay, not on the body, the most common setting, healthcare setting. Do you know where most pressure sores occur? You would think, actually, no. Who said hospital? Hospitals, right? Hospitals is the one place you would think this would never happen. But in nursing homes and assisted living facilities, we've trained you guys, make sure these guys get turned. In the hospital, this gets overlooked. More people come back to a facility with a bed sore from the hospital than you would imagine. It's crazy. So those of you who want to go into the hospital, please understand this is not a long-term care problem. This has to be addressed by you as well. And if your care plan does not tell you to turn this patient every 2 hours and you know they're not turning on their own, who should you be bringing that up to?
The nurse.
The nurse, absolutely. I want to tell you guys, I really do. I want to tell you that every nurse out there is good, but they're not. They're not. They're pushing people through nursing school that have a vague understanding, but no real application. You are going to have to stand up for the patients. If you know that this patient is not moving on their own and there's no order to turn them and you're in a hospital setting, you should be going to the nurse and saying, hey, there's nothing on there about turning that patient. Do you want me to turn them every 2 hours? And the nurse will go, oh, yeah, do that. You don't have to have a written. It's part of the care. If they're telling you it's part of the care plan, just do it. Okay. Good. Good. All right. So the way we do this, every 2 hours around the clock, we're going to start out with the patient on their back. 2 hours later, we'll go to the right side. 2 hours later, back to their back. 2 hours later, left side. 2 hours later, back to their back. We have fewer nerve endings on our back. So that's why our back gets more often. Okay. So then we don't have to worry about this.
So for this is for like strictly for the ones that just can't turn at all.
Aren't moving at all. Okay. Because just like you at home, I'm not going to come into your room at home and flip you over when you can do this on your own. So if they can turn on their own, they're fine.
What if we notice improvement? Can we stop?
You can notify the nurse. You don't make decisions.
Right.
We can notify the nurse. Hey, they're turning really well on their own now. Do you still want me to be flipping them every 2 hours or what are we doing here? Okay. You should be working together with the nurse. It should never be you versus the nurse. If it's you versus the nurse, right? If it's you versus the nurse, no one's taking care of what's trying to kill the patient. If it's you and the nurse on a team, now we can fight what's trying to kill the patient. But if it's this, that patient is one that's going to suffer. Good? Make sense? All right. So back, right, back, left, back, right, back, left. Notice there's no tummy on there. We do not put immobile patients on their stomach unless you're specifically told to. Very important. Because of gravity, right? My back has a lot of muscles and bones that gravity is going to pull down. So if I've got the patient on their tummy, right? And if I've got the patient on their stomach, everything in the back is going to press down. That is going to squish those lungs. And those lungs may not be able to open enough to breathe. So we don't put patients on their tummy unless we are told to specifically. Now, I am going to tell you that this was interesting to me because I've been teaching this for a very long time. During COVID, we had a lot of people on ventilators, a lot of patients on ventilators. And some nurse in an ICU somewhere put a patient on their stomach. Now, I'm not sure why they came up with that idea. I have no idea. I'm thinking that respiratory therapy was involved. I don't know. I never interviewed this person. But put this patient on their stomach and respirations improved. O2 sats improved. Ventilation quality improved. So that kind of went out. And hey, if we've got somebody that you're having a really hard time ventilating because of COVID, now this doesn't work with anything else, but because of COVID, try putting them in a prone position. And it worked with a significant part of the patient population. The ventilation, what we call the VQ ratio, was improved. And I think it has to do because of microclots. Okay. So there's a lot going into this, I know. But those care plans said, right, back, side, front, side, back, side, front, side. So those care plans were a little different. How do we know what to do as a CNA? Follow the care plan. Good? Make sense? Okay. For the most part, though, we don't put patients on their tummy unless you're told to. Remember that the patient must always be in the middle of the bed. So if we are turning if the patient's turning themselves, they'll do this automatically. But if we are turning the patient, make sure you scoot them towards you and then roll them away. Good? Don't let them be on the edge of the bed. That's not a safe place. So we'll scoot them toward us, roll them away from us so they're in the middle of the bed after the turn. Now, this patient is not immobile. Our care plan did not say they were immobile. It just says they can't turn on their own. But what if we do have a patient who's immobile and can't scoot toward us? What do we do then? Well, we can use a draw sheet. A draw sheet is a flat sheet, just like this. This is a flat sheet. It's folded in half lengthwise. So if I were to fold it like this in half lengthwise, remove all the wrinkles and put it underneath the patient, under the patient. Now I want this end, the folded end, right about here between their shoulders. I want that end, or the two halves that meet up, down here under their thighs. Now, if I've got that sheet on the bed, folded in half lengthwise between their shoulders and their thighs, I can use it as a sling to pick it up and pull that patient toward me. That is called a draw sheet. And it helps move patients when they're in bed. Now, if we don't have a draw sheet for whatever reason, you can move a patient in segments. Move their shoulders and head, their torso, their hips, and their legs. We also have other things called slide sheets. These things are like space age technology. They're super, super cool. They're super slippery. They're not wet though, but really slippery. You put it under a patient, you can just kind of woo, and they move. It almost levitates them. It's super cool stuff. The problem is they're very expensive. So they're probably locked up in a supervisor's office somewhere. You'll have to sign them out so everybody knows who's got it. And then you'll have to sign it back in so that they know you didn't steal it and sell it on the black market. So. Huh? They do, yes. Yeah. So when we're preparing to move a patient, to turn them on their side, preparation is everything. I told you I took care of bariatric patients, super morbidly obese patients. I can turn somebody about 3 times my body weight easily using this method. And it doesn't hurt them or me. So we get the patient scooted toward us, and then we prepare them. So the furthest arm goes above the head. So remember, I've got to figure out which side am I turning them on. This care plan said turn the patient on their left side. I think it says left. Read the care plan at the top of that page for me. Right here.
Yeah. On his
Left side. All right. So I'm going to turn this patient on the left side. So if this is my patient in bed, Jake, adjust that for me. If this is my patient in bed and I'm going to turn her on her left side, I would be over here. Because remember, I always have to turn the patient away from me, right? So you've got to be on the side of the bed behind the patient after the turn. So I would be over here. Now, the furthest arm is going to go up over their head like this. And she doesn't move real well, so I can't really demonstrate on this on her, but it goes above the head like this. The closest arm to me would cross the chest like this. Good. Furthest arm up, closest arm over. Now, if I were to turn her on her right side, I would be on this side of the bed. Furthest arm up, closest arm over. Good? Make sense? That would be in the care plan. It would tell you what to do about that specific patient. But in general, furthest arm up, closest arm over. Furthest arm up, closest arm over. Good? Now let's go to the legs. The furthest leg away from you, the knee is going to get bent and angled out. So it's going to look like this. So we put the foot on the bed, bend the knee, and angle that leg out. The closest leg to you, the foot will be on the bed. So we just bend that knee, put the foot on the bed. So arm up, arm over, leg up, and leg angled. Good? Now, when you do this, these patients they almost levitate. They become so easy to roll on their side because they're like half on you've moved all of their extremities to that side. So this becomes a very easy turn. Now, if I don't set it up like this, if I just have a patient laying there like this and I try to roll them, it's going to be a whole lot of work because I'm trying to move their whole body weight and their extremities are out just wailing away. So we have to prepare the patient first to make sure they're in the right position for the turn. And when you do that, you can turn somebody 3 times your body weight with no problem at all. Good? Now, once we get them on their side, so arm up, arm over, leg out, leg up. Once we get them rolled onto their side, we have to use some pillows to keep them there because gravity is going to try to pull them back onto their back. Gravity just does that. Most of our weight's distributed along our back. Gravity will try to pull them onto their back. So we're going to read the care plan. We're going to do our opening. We're going to figure out if we need gloves. We might. This patient is leaking somewhere. I need gloves. For the test, your patient's fully clothed and holding onto all their own body fluids like a champ. Probably won't need gloves for the test. Remember, it's by patient, not by skill. So we'll evaluate if we need gloves. We're going to get our barrier, put our pillows on our barrier, use a privacy blanket to keep that patient covered. Don't hold those pillows up against your uniform. Make sure the patient's in the middle of the bed after the turn. So here's your checkpoints. Your checkpoint says assist resident with turning on the side before placing positioning devices. Well, that makes sense. You got to get them on their side before you start putting pillows in place. Don't put pillows in place and then turn them. Pillows are going to go everywhere. Not helpful. So turn the patient, then put the pillows in place. We want to keep the patient positioned to safe distance from the edge at all times. Well, we already talked about that too. After we turn, that top leg needs to be in front of the bottom leg. You don't want those knees sitting right on top of each other. That's not comfortable. Just not comfortable. Make sure those knees are not right on top of one another. That's what that checkpoint is about. Then we're going to put a pillow behind the back in a roll. So I'm going to take the pillow long ways, tuck the edge of the pillow underneath the patient's back, roll it up, and then tuck the other edge under the patient's back. And this is going to create a roll behind the patient that will keep them from rolling backwards onto their back.
How many pillows do you have to use for the test?
So for the test, we're going to use 3 additional pillows outside of the one that's under her head.
Okay.
So we're going to go get 3 pillows. Mm-hmm. We want to put a pillow between the legs, specifically between those knees and ankles. Remember that top leg should be in front of the bottom one, but you want a pillow there to pad. So pillow goes between the legs, and you're going to get 2 checkpoints for that. We're going to put a pillow under that top arm. Make sure it's not covering the face, but we're going to put a pillow under that top arm to keep it in a neutral position. When the arm is like this, just against the body, it pulls downward, and that can cause muscle strain up into the neck, can cause headaches, muscle spasms. So getting that arm on a pillow puts this in a neutral position. Make sure it's not over the face though. And then we'll adjust the pillow under the head. Now take a look at this real quick. Do you see how the arm was on top of the pillow during the turn? After we get all these other pillows in place, we're going to address this. We're going to put that arm under the pillow and make sure that pillow is only under the head and neck and not that bottom shoulder. Once you get all of those pillows situated, and again, you get 2 checkpoints for that. Once you get all of those pillows positioned, we're going to put the call light in the bottom hand. The bottom hand, because we don't want that cord to come across that neck. So we put the pillow in the bottom hand. So I just kind of raised that pillow up so you could see that's going in the bottom hand. Good. And this is a checkpoint specifically. Thank you. So, oh, Jake, give her the packet, please. It says specifically, leave call light in or near resident's hand on side turn toward. So they're specifically telling us which hand to put that call light in for the test. And then we'll do our closing just like we always do. So please remember that this care plan is for this one patient. It doesn't work on this one or this one. This care plan is only for this patient. So all the variations you have in your head would create a different care plan based on what's going on with that patient. Good? Questions? All right, so let me show you this video. I forgot to load. Jake.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to turn you onto your left side. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies, and I'll be right back.
Okay.
I'll start gathering your supplies. We'll start with a barrier, which I'll place on the table to provide a clean area to place my supplies. And I'll get 3 pillows from clean supply cabinet, being careful not to allow them to touch my uniform. Mr. Jones, I'm going to place this blanket over you, and this will help keep you warm and protect your privacy while we do this skill. Once I have the blanket in place, then I'll pull the sheet down underneath the blanket, making sure the patient remains covered at all times. Okay, Mr. Jones, if I could have you scoot toward me, please. I'm going to place your furthest arm above your head and cross your closest arm over your chest. I'm going to bend the closest knee and put the foot flat on the bed. And I'm going to angle the furthest knee out a little bit. Okay, now I'm going to turn you onto your side. 1, 2, 3. Okay, I'm going to take the first pillow and put it in an angle up against the back, and I'm going to tuck this top edge underneath the patient by pushing down on the pillow and under his back. This edge will roll up, and then it too will be pushed down and under, forming a roll along the back. Okay, now I'm going to position a pillow between the 2 legs by lifting the top leg and laying the pillow lengthwise between the 2 legs, specifically between the knees and the ankles, to prevent those bony areas from rubbing together. This pillow is going to be placed underneath the upper arm. This will help keep the arm in a neutral position as the patient remains on their side. And then I'm going to adjust the pillow underneath the head to make sure that it's not under the shoulder and it remains only under the head and the neck. And then move the arm to a more comfortable position. Is that comfortable, Mr. Jones?
Yes.
Okay, I'm going to place the call light directly in your hand. Are you comfortable?
Yes.
Can I get you anything else while I'm here?
No.
Okay, let me pull your sheet up. And remove the privacy blanket. Being careful not to dislodge all of those pillows as I do so. I'll roll the privacy blanket up and place it in dirty linen. The barrier will be thrown away. Okay, Mr. Jones, I'm going to open your privacy curtain now. Is there anything else I can get for you while I'm here?
No, thank you.
Okay, I'll see you soon. Let me go wash my hands. After washing my hands, I'll review all the steps of my skill, make any corrections, and tell the evaluator my skill is done. Oops. The video had me put the call light in the top hand. Please remember it is in the bottom. So this is the next video I'll be working on. I have a new computer desk coming today I'm super excited about. And I have a new computer coming in about 2 weeks that's going to let me edit these videos a little more effectively because mine is old and worn down and not working right. All right, so any questions on what we've learned so far?
Does it matter the order you do it?
No. As far as the pillows go,
Yeah, like the whole order. It doesn't matter how you.
well, you have to turn the patient before you put the
Right,
pillows
but
in.
The pillows don't
The
matter.
pillows, yeah, there's no order requirement on that.
So you can do back or whatever.
Yeah. Since I've got them, since I roll them away from me, I'm right there at the back. So I do the back and then the leg and then come around to the other side for the top arm pillow and then the hand pillow. So you just kind of work my way around the bed, but there's no checkpoint that says does it in that order. You're free to adjust. All right, any other questions? Let's go ahead and take our break. The next 2 skills we have are pretty easy, and then we're going to get into test registration. So go ahead and take your break.
have no more kids. She will not
Okay.
make it past her term. So
Okay, so let's get into our next skill. We're going to learn foot care. The synopsis of this, or the short form, is on page 118. You can see all of the principles that are involved. They're all spelled out for us here. The short version of the skill is here. And then down here is information about the test itself. So somebody with your level of experience should be able to do this in 13 minutes or less. It will be done on another live testing student. So you might be a patient for this skill. And I know nobody likes having their feet messed with. I get it. But this is still something that needs to be demonstrated for the test. That person will be positioned in a chair at the beginning of the skill, not in bed. And then our step-by-step instructions are here on page 119. You can see the care plan at the top of the page. Down here at the bottom are your supplies. Here's our care plan. It says provide foot care to 1 foot using soap and water. You get to pick the foot. They don't care. The test figures that if they watch you soak 1 foot, wash 1 foot, dry 1 foot, lotion 1 foot, and put the shoe and sock back on 1 foot, they don't need to see it on the other side. You've got it. You only need to do this on 1. In a clinical setting, if you're going to do foot care on 2 feet, you can do them both at the same time. Put them both in the basin, take them out. If both feet don't fit in the basin, do them 1 at a time. Okay. That doesn't really matter. But for the test, we only have to do 1. I will tell you that for the test, remember those evaluators? They want to be at home in their pools, drinking their margaritas. They don't want to be doing this. So, yeah. And they test on Sundays
and
too.
Sundays, yeah.
So a lot of times when we're talking about foot care and ambulate, which is another skill we're going to get to very shortly, when they check you in, they're looking at you head to toe. And they're looking, for instance, you have shoes that just slip on. So do you. So do you. So you guys would be pretty good candidates for this because it's quicker. It speeds the skill up, right? Nobody has to, struggle to put your shoe on, tie the shoe, all of that. So it's a little bit quicker to get the skill done. So they take things like that into consideration when they're pairing you up to do this. Believe it or not, things like what you wear that day will impact who you're going to be partnered with.
So I want to make sure I wear boots that way they won't.
Yeah. Closed-toed shoes you have to wear. It doesn't say what kind. All right. So there's our care plan. These are the principles involved and the test-specific information. We already know everything we need to know to do this skill. We just have to learn the test-specific or skill-specific information. Now, foot care is an awful lot like hand and nail care. With hand and nail care, we put the hand in the basin to soak. With foot care, we're going to put the foot in the basin to soak. With hand and nail care, we took the hand out to wash it. With foot care, we'll take the foot out to wash it. With hand and nail care, we made sure that hand was on a towel when it was out of the basin. For foot care, we'll make sure the foot is on a towel. All of that is the same. We're going to rinse the same. We're going to dry the same. We're going to put lotion on the same. All of that is the same. What's different here is that we're not going to clean under the nails. So with hand and nail care, we use an orange stick to clean all debris out from under the nails. We don't do that. We don't do anything with toenails. We don't clean them. We don't trim them. We don't file them. We don't do anything with toenails other than look at them. Because facilities have a podiatrist or foot doctor that comes to the facility about once a month. But they don't go room to room and say, hey, do you need me? Do you need me? They don't do that. They go in and they look at a list. Patients have to be on the list to be seen. So you do foot care. You notice there's an issue. You notify the nurse. The nurse puts the patient on the list. And when the podiatrist comes in, they get seen. Good? So all we're doing on nails is looking at them. When we put lotion on, we won't put lotion between the toes because lotion between the toes can hold in moisture and it's already warm and dark there. So we don't want to hold moisture in. So no lotion between the toes, but everywhere else is good. We're going to wipe off that excess lotion just like we did for nail care. So we're going to read our care plan because that's where we start everything. All skills start with the opening. The opening starts with a knock. We know this. We're going to evaluate if we need gloves. Now I'm going to tell you, you need gloves. And the reason you need gloves is because we don't know if there's a wound, right? The whole reason we're doing this skill is to actually look at the foot. The whole reason you're there is to look for something to report. So because we don't know if there's something to report, that's a maybe, and a maybe needs gloves. Good. It's also feet. I mean, a lot of us have a thing with feet. We don't want to touch people's feet. So gloves are definitely indicated with this particular skill. Yeah. Now, if I'm doing this on my mom,
I'm using gloves.
Yeah. If I've been doing foot care on my mom and I know there's really nothing there to worry about, you know, I may make the judgment call, but for the most part, I'm probably going to wear gloves. It's feet. Okay. Good. Now we are going to use a barrier for this skill, but this time the barrier is going to go on the floor, not the table. And that's because the patient is probably not going to be able to get their leg up here to put the foot in the basin. That's just not comfortable. And we don't want water on the floor. So we're going to put the barrier on the floor, which is where we're going to be working. Now, this skill does require that you get down on the floor. The test centers, as far as I know, despite numerous petitions, do not have rolling stools. You know, the little low ones. They should. And there have been multiple petitions for it. But as far as I know, they do not have those little rolling stools. So you'll actually have to get on the floor. If you want to put a barrier down for you to kneel on, that's perfectly okay. You are allowed to do that. You can even put a towel on that barrier if you have bad knees like me and you need something softer to kneel on. Don't put the towel directly on the floor, though. On top of the barrier, right? No linens touch floor. That's a rule. But you can put a barrier, a second barrier on the floor for you to kneel on. Good? Good. We're going to get the rest of our supplies. Don't hold them against your uniform. So linen rules are going to apply here. We'll put those linens on the barrier, not on the floor. Then we're going to go get our water. We'll check it. They'll check it. Make sure it's okay. Whatever we wash, we rinse. Whatever we rinse, we dry. Make sure when you're moving the leg, you're providing some support. We'll get to that in just a second. Patient always checks the water temperature. We're going to wash the basin at the end of the skill, just like we always wash the basin. We're going to rinse it, dry it, store it. No fuss, no muss, just rinse it, dry it, store it. Use some paper towels so we don't recontaminate. Now, skill specific. At the bottom, because I made these slides for you guys yesterday. So at the bottom, you can actually see the check. I put the checkpoint on here for you. So the checkpoint says soak resident's foot in a basin of water. It does not tell us how long. They don't care. Put the foot in the water and then take it out. There's nothing here that says 5 to 10 minutes. Good. The checkpoint just says soak it in a basin of water. We're going to provide support anytime we move that leg. So support under the calf or knee and under the heel. Don't just grab the leg and move it. You want to provide support from underneath. This is what they're grading us on with washing. Did you wash the top and bottom of the foot and between the toes? Did you rinse the foot, including between the toes? And did you dry the top and bottom of foot, including between the toes? That's what they're grading you on. Did you wash, rinse, and dry? It doesn't say anything here about how to do that. Okay? It just says, did you wash, rinse, and dry? So you'll see a ton of videos out there on YouTube that show all different ways of doing foot care, and they're all right because it doesn't tell you exactly how to wash, rinse, and dry. So some places use a mitt. Some videos will just use a washcloth wrung out, right? They don't care. Nothing here it says. Good. Now, when we put lotion on, we don't want lotion between the toes because that holds in that moisture. So lotion on the top and bottom of the foot, but not between the toes. It's a checkpoint. But this is really why you're there. You're there to look. So as we're doing all this cleaning, we should be looking at all surfaces of the foot. And I'm going to explain to you why this is so important in just a minute. Oh, actually, I'm so sorry. I moved this lecture to Monday. So we're going to talk about diabetes and insulin on Monday. Okay. And I'll explain to you why looking at that foot is so important. All right. You want to keep the foot on the barrier. This is a graded checkpoint. To me, this is kind of a common sense thing. You wouldn't want a bare foot on the bare floor. I don't know why they have to put this as a checkpoint, but because they have it as a checkpoint, it means lots of people did this. So just don't put it on the bare floor. That just kind of makes sense to me. Yeah. Yeah. And then it wants us to put the sock back on, removing wrinkles, and then put the shoe back on and fasten it. Those are graded checkpoints. Now, let me talk to you about the sock, though. In a clinical setting, if you've gone through all this trouble to soak the foot, wash the foot, rinse the foot, dry the foot, lotion the foot, and you've looked at the foot, you're probably not going to put nasty socks back on the foot. You're going to get some clean socks and put those on instead, right? That's a common sense thing. The problem is that this is going to be done on a live testing student, you. And you probably did not bring a clean set of socks with you to the testing center, did you? No. So we don't have clean socks to put on for the test. So our care plan is going to tell us to replace the sock and shoe, which means whatever they wore in is what they're going to wear out. But in a clinical setting, please remember, clean feet deserve clean socks. Okay. For the test, we don't have clean socks, so we're going to make do with what we got. Just make sure you remove the wrinkles. And then do your closing. This is probably one of the easier skills. You're soaking a foot, rinsing a foot, washing the foot. I'm sorry. Soaking the foot, washing the foot, rinsing the foot, drying the foot, and putting some lotion on everywhere but between toes. Put their sock and their shoe back on, clean up. It's not a long skill. It's not a hard skill. And they're giving you, 11 minutes to get this done. That's like crazy amount of time. Now, for me, this is a hard skill. For me, because I don't get on the floor very well anymore. My knees are really, really bad. So we retaped all of these videos. And you've seen some of the new ones. I'm still in the process of editing the others. But this one was a really hard skill for me because it's really hard for me to get on the floor. Do you think the test cares? No. Nope. So even if you have bad knees or have difficulty getting on the floor, you still have to be able to demonstrate this skill. So this is one that if you have some knee problems, you're going to want to practice it to figure out the right way to do it for you. Nope, they're just going to ask you when you come into the test, do you have any conditions that would keep you from being a patient for any of these skills? Not a CNA, a patient, because they figure if you're here to test, you can do CNA work. Okay. Make sense?
Mm-hmm.
Good.
What about when you become like an older CNA? I know a couple people that I work with. They just tell about looking at them.
Yeah, so here's the thing. I'm going to get on my soapbox for a second, okay? We should be working as a team. We should, because that's how we get the best care for this patient. I have strengths. I have weaknesses. You have strengths. You have weaknesses. Now, you probably can get this patient out of bed lickety-split because you're taller and stronger than I am. So I'll tell you what, you do all my patient movement for me, and I'll do all of the personal care for your patients. and we're going to lean on our strengths, right? Well, one of my weaknesses is foot care. So, hey, I'll do your personal care for you. Can you do my foot care for me? Okay, we're going to work as a team. Now, the problem with team, and we used to have something called team nursing. And this is the way everything worked. Like the three of us would have a hallway, right? Those are all of our patients, not room 2, 4, 6, and 8, right? It would be all of our patients and we would work as a team and it was awesome. But the problem is that in every team, there's always one person that doesn't want to pull their weight. And they're out on break way too much and they only want to do the easy stuff. And, you know, they lean heavily on the other team members and there was just too much of that going on. So facilities are like, okay, well, you guys are all responsible for your own stuff now, right? So I believe in team nursing. I think that the patient outcomes are the very best when we have a dedicated team to see to all the needs of the patients because we have strengths and we have weaknesses. If you are fortunate enough to work at a place that has team care teams, don't be the weak link because you can ruin it for everybody. If you're working at a place that doesn't do teams, you're going to have to do the best you can. It's really kind of that simple. And it's really sad to me that just a few horrible people have ruined that dynamic for everybody. I think it'd be better to get rid of the few horrible people. You know, but I don't run the facility, so I don't know. I'll tell you what, if I ever become, and the thought has crossed my mind on many occasions to become a nursing home administrator, because I know enough on how to run a facility where I would get good quality patient care out of my workers. And I would make sure that the workers had the support that they needed to provide that good quality patient care. And if I ever get to that point in my life, I would only hire my students. It would be that simple. I would only hire those that I trained because I would want to make sure that you are in it for the right reasons, that you're here for the patients and not the paychecks.
Common issue that I've noticed, and I've been to about 5 facilities in the last 2 years. A lot of the CNAs, they do hide, go out on smoke breaks, and sit in their car for like 2 and 3 hours at a time.
Yep.
And everything just falls apart. And then they turn around and they talk down to, let's just say, the kitchen staff because X, Y, and Z wasn't communicated with the kitchen staff.
Right. They look down on everybody, unfortunately, you know, kitchen staff activities, you know, front office people, all of that. I've seen that. I actually caught a CNA once sleeping in a bed that a patient was currently in.
Sleeping with the patient? That's against the rules.
Sleeping on the job is against the rules. Yeah, sleeping in the bed with an immobile, unresponsive patient. Just kind of scooted him over to the side and laid down. Oh, I know. I'm telling you, I could make a podcast. Let me tell you, I've got an entire folder of ethics. And that's just what's in our local news. That's just local news. I mean, that's not even like national. I had to turn my filter off. I had a filter going where it would, you know, send me, you know, articles that, you know, from if CNA or nursing assistant was mentioned. I had to turn it off because my inbox was just overflowing. And that's why I do that's why, guys, you all paid money to sit in this class. But if you called me and you talked to me on the phone, I told you that you could watch the live streams. That's why I do this. That's why we have people watching. Yeah. So I do this because I need more people that know what they're doing out there And I know that a lot of people either aren't in our geographic area or can't afford to take this seat. They shouldn't have to do cut rate education, which is going to make them an inferior coworker for you later. Everybody needs to know this stuff if you're working in healthcare. Everybody. In your video, it shows doing foot care without an orange stick and emery board, but the teacher taught it different. And it is listed to do that like hand care. Is that the new way to do it? Well, Shauna, I'm not sure what state you're in. If you can tell me what state, that would help, because different testing vendors have different requirements. Now, here in Florida, we have Prometric, and Prometric standards are the same throughout the country. So it doesn't matter what state you're in. If you're taking a Prometric test, New York, okay, New York has Prometric. So let me go back real quick. Okay. So if we go to, okay, if we go to here, right, or we started talking about, so these are the actual checklists that you are going to use in Prometric when you test in New York. This is the actual checklist. So watch this down here as we go through this. We're going to soak the resident's foot in a basin of water. We're going to provide support to the lower extremity when we move it. We're going to wash the top and bottom of the foot, rinse the top and bottom of the foot, and dry the top and bottom of the foot. And we're going to apply lotion, but not between the toes. Nowhere in there does it say to use an orange stick and an emery board. It is not on the checklist. So I'm not sure what checklist your instructor is using. And it may be on that checklist. I don't know. But I do know that I made these slides yesterday, and these are the checklists on Prometric's website as of yesterday. So it's not on the checklist. I'm not sure what your instructor is using for a checklist. They may be using something different and go by what your instructor tells you to, but it is not on this checklist. And this is what you're going to use in New York for Prometric. It won't, not for Prometric. Prometric care plans are published and they can't change them. The evaluators have no control over that. And that's because, so here's the thing about standardized testing. It's standardized. It's standardized. So if you take the SAT in New York or you take the SAT in Florida, it's the SAT. If you take the CNA test in Miami or you take it in Jacksonville, it's a standardized test. It is exactly the same. So these care plans can't change.
But just in general, like if you went to a facility though, could that pop up like to file, or we just never touched their toenails?
How do I put this? This is a hard question. I'm trying to figure out how to phrase it. Okay. Go by your care plan. Now, the nurse that wrote the care plan may or may not be informed of the policy and procedure at your facility and the state regulations. Okay, because remember, in order to delegate anything, I have to know those two things. And if my policy and procedure does not say that CNAs can trim toenails, and my state guidelines say my CNAs cannot trim toenails, but I put it on the care plan anyway, that's on me as the nurse. You follow the care plan. That's what you do. That is, but you have to be trained to do the task. Now, you haven't been trained to clip toenails. So what would you say? Haven't been trained on it. Not in my scope of practice. Haven't been trained on it. No, they can train you. That's okay. They can train you. And then it's under them. Because you've been trained and it's on the care plan. That's all them. That is all them. But I'm going to tell you, as a nurse, there is not a CNA on this planet that I would have trimmed toenails. Ever. No situation. No situation. No situation. Remember, I'm accepting responsibility for that. I have the liability. If I tell you to do something and you've been trained to do it and you do it, I have the liability for it. And the likelihood of you as a low paid CNA who probably is there for the paycheck, not the patient, right? You aren't probably going to pay really close attention and take the time and care necessary to avoid cutting their skin. It's just too high of a risk. It's way too high of a risk when it's my license on the line. So there isn't a CNA on this planet that I'm willing to delegate that to. Not a single one. Not a single one. If the patient's nails need clipped as a nurse, I will do that. Thank you very much. But toenails, I'm not even doing. That's what I got a podiatrist for. That's just not my wheelhouse. Thank you very much. No, thank you. Not doing it. I am putting that patient on a podiatry list and I'll let them pay the big bucks to have that done. Not me. No way. All right. So I hope, it's Shauna, right? I hope that helps answer your question. And you have access to, all of you guys have access to all of these checklists. Every one of you has access to these checklists on Prometric's website. We're going to get there today. I've got a whole presentation on Prometric's website. We're going to talk about test registration. You have access. So stick around. In about 50 minutes, I will be talking about that. And you should be printing off those checklists yourself to be able to go through them so you can see what am I being tested on. Now, your books that you guys all have in class, I've taken those checklists and written step-by-step instructions for you. So your books are up to date. Most of my videos are up to date. I'm still working on some of them, but most of them are up to date. But go to that. Always go back to the source. Don't even trust me, guys. I'm a human. Yes, I am a subject matter expert in prometric testing, but I'm still human. I might be having an off day. Don't trust me. Go to the source. Go print out that checklist and see what you're being graded on. Okay. So these are the rest of the checklists. All right, so remember that this care plan, let's read it one more time, tells us to provide foot care to 1 foot using soap and water. The resident is sitting in a chair and their sock and shoes should be replaced at the end of the skill. So again, no clean socks. This is for this patient, not this one, not this one, not you. This care plan is for this patient. Now, if my care plan said to trim toenails and I've been trained to trim toenails, I would trim toenails because the care plan told me to. And I've been trained to. But this doesn't tell us to. This is for this patient on the test. Good? Make sense? All right. So go ahead and show the video, please, Jake.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
Wonderful. I need to do foot care. Is that okay?
Yes.
Let me go close your curtain, wash my hands, and then I'll gather your supplies.
Okay.
Okay, I'm going to get a barrier, and we'll place this on the floor right in front of you, and you can place your foot on the barrier. I'm going to get a basin, soap, and lotion. We'll place that on the barrier. I'm going to get 2 washcloths and a towel and a set of gloves. I'm going to get some water for washing. Okay, Mr. Jones, would you like to check the water temperature and make sure it's okay?
Yes.
Is it
Great.
good?
Yes, great.
Very good. I'm going to set this here. And I'm going to kneel on the barrier and apply my gloves. I'm going to roll up your pants leg and lift your foot so I can remove your sock. We'll place your foot in the basin to soak. I'll take the first washcloth and wring it out, making sure that your foot is wet. I'm going to place your foot over here on the towel and apply soap to the washcloth. I'm going to wash all surfaces of the foot. I'm going to lift your foot up so I can wash the bottom, and I'll observe for any red areas, wounds, sores, or any other abnormalities. We'll put your foot back in the basin to rinse. Okay, I'm going to place your foot on the towel to dry. And I'll ensure all surfaces have been dried thoroughly. I'll take one of the narrow edges and go between your toes to blot. And I'll dry the bottom of your foot. Now I'm going to apply some lotion. We'll warm the lotion in our hands and apply lotion to all surfaces except between the toes. So I'm going to lift your foot and we'll apply lotion to the bottom as well as the top. And now I'm going to wipe off the excess lotion so that you don't slip. Okay, go ahead and place your foot back on the barrier. And now I can reapply your sock. There you go. And we'll put your shoe back on. Can you slide your foot in there for me, please? Okay, Mr. Jones, I need to put all of my supplies away now. I'm going to gather my dirty linen and place it in the dirty linen hamper. I'm going to take the basin to the sink and clean according to the basin cleaning procedure. On the way back, I'll collect the soap and the lotion and put the basin back in the drawer. Now I'll collect the barrier and throw it away. Now I can remove my gloves. Okay, Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is here. If you should need anything at all, please let me know. Can I get you a magazine while you're waiting?
No, thank you.
I'm going to open my curtain and wash my hands. After washing my hands, I'll review the steps in my skill, make any corrections, and tell the evaluator my skill is done. Okay, any questions?
I have a question of because I know the care planners say that they're already sitting in the chair, but I know as CNAs we're responsible for all their ADLs, so most of the time would they be already in the bed and then we have to get them to the chair?
They're going to be all over the place. They may be in the activity room. You may have to bring them back to their room. They may be in a wheelchair. They might be in bed. They might be in the chair at the side of the bed. For the test, they just had to pick one, you know, in order to be standardized. So for the test, they just picked, put them in a chair.
I think it's all about the skill, like cleaning in general.
Right.
Right, but just in general, like when we are actually, working and
So
stuff, I'm
it's-
assuming we'll have to add the extra steps of the other.
Yeah, that's gonna come with it.
Right. So let me kind of give, this is something I usually talk about a little bit later in the program, but let me address it now. So when you see these skills that we're doing, right, what I'm showing you, do you guys remember high school? Do you remember the yearbooks you got from high school? They had like snapshots in them, right, of big games or, voted most popular or, the different clubs. It's just a snapshot. That snapshot doesn't tell you what happened before, what happened after. It's just literally a snapshot of one moment. That's what these skills are. They're snapshots. So they're when you're doing hand and nail care, you may also be brushing their teeth right afterwards, because we're going to do everything. When you're doing dressing a resident, you might actually do foot care while you're getting them dressed so that you can put, shoes and socks on. We're going to group these skills together based on the needs of our patient once we're out there working. But remember, when we're learning, it's literally a snapshot. I think of them like Polaroid pictures. They don't tell the whole story. They're just telling this particular moment with this particular person. Does that make sense? So in a clinical setting, you're probably going to be grouping all of these skills together in some manner, some way, shape, or form. Okay, and that may mean getting them from the activity room or getting them out of bed and putting them in a chair or whatever. This is hard to do in bed. Have I done foot care in bed? Yes, I have. We don't soak.
Oh, you wipe it.
You wet the washcloth and you wash.
So you can do it in bed?
Sure. You wash, you rinse, you dry,
As long as they get done, right?
you lotion. Yeah.
As long as you do the procedure.
Yeah, you just can't really soak effectively. Yeah. So it really kind of depends on the needs of the patient. Okay. Good. Makes sense? So let's talk about mouth care since we're on the subject. All right. So mouth care starts on page 92, shows you all of the principles involved, skills specific, short version, video. Down here is test specific information. Somebody with your level of experience should be able to brush somebody else's teeth in 12 minutes or less. How ridiculous is that? 12 minutes. 12 minutes. And here's the thing. They aren't even grading on how long you brush the teeth. So you don't have to brush for 2 whole minutes. 12 minutes they're giving us. This is a live patient skill. So one of you may be a patient for this. That person will be in bed. Charting is not required for this skill. So let's take a look at page 93 at the top of the page. You'll see the care plan, the bottom of the page. You'll see the supplies, and your step-by-step instructions are listed there in detail. Here's your care plan. It says a resident with natural teeth is lying in bed and needs mouth care. So time out real quick because somebody's about to ask, what about if they have dentures? That's a whole different skill that we'll be going over next week. This patient has natural teeth. So it asks us to provide mouth care and the resident's not able to provide their own mouth care. Let me tell you something. If the patient can brush their own teeth, they will brush their own teeth. Nobody wants you in their mouth if they can do it themselves. I can guarantee you that. This is a very personal skill. As long as a patient's able to, they'll do it themselves. You're not going to brush everybody's teeth. You're only going to brush the teeth of the people that need it. Good? Make sense? This is one, as long as I can hold a toothbrush, I'm brushing my own. Thank you very much. Do not get into my mouth. unless you got a reason to be there. All right, nothing new to learn, just skill specific. So let's get into the skill specific steps. Of course, we're going to read the care plan and we're going to do our opening. We're going to need gloves because there's body fluid, saliva. So we need some gloves. And of course, we need a barrier to put all of our supplies. These are not new things. We already know these things. Now, linen rules are going to apply here because we have to get a towel. So we don't want to hold the towel up against our uniform. Anything extra that we take and don't use gets discarded. We know these rules. Nothing new to learn here. But let's get into, we're going to clean the basin the same way we clean everything else. Rinse it, dry it, store it. But let's get into our skill-specific steps. And again, I've actually put the checkpoints right on the screen for you. Safety first. Your patient is laying in bed. Is this a safe position? No. We have to get this patient sitting up. So let's look at the care plan here. It says assist resident to a sitting position in bed by raising the head of the bed and using pillows as needed to position the resident upright, 60 to 90 degrees, before offering fluid or brushing teeth. So that means this head of the bed has to be up, not a little up. It's got to be up. Good? Okay. Now, it wants us to raise the head of the bed and use some pillows to get them sitting up, because when you raise the head of the bed, that pillow that's behind their head, really comfortable when you're laying down. But when you get into a sitting position, that pillow pushes your head forward. This is not comfortable, nor is it safe. So what we're going to do is slide that pillow down behind their back, their upper back, to get them into that sitting position. Can we touch a person without washing our hands? No. So this has to happen after we've washed our hands. Keep that in mind. We're going to get to that in just a minute. Just keep that in mind. So head of the bed is going to go up. Now, if the patient is mobile, you might get them sitting on the side of the bed, as long as they're upright. But we would go by our care plan. Since our care plan doesn't say the patient can sit on the side of the bed, we're going to raise the head of the bed. Good? Okay, remember that pillow has to be adjusted. When you get the head of the bed sitting up, that pillow is going to put that esophagus out of alignment. It pushes that head forward a little bit. So we want to get that patient sitting up and then slide that pillow down. Let me go back here real quick. Do you guys see this? There are a few steps on a few skills that missing that step is an automatic failure. This is one of those. If you try to brush somebody's teeth with them in a laying position, you will fail the test, period. There's no coming back from this. And that's because the evaluator will wait until you're just about to put the toothbrush in the mouth, and they're going to stop the test. And they're going to say, I need you to put the head of the bed up, please. Now, because they've told you, you can't get credit for that step. Got it? And this puts your patient in jeopardy. This can kill your patient, brushing your teeth with them in a laying position. They'll give you every opportunity, but the second you get that toothbrush near their mouth, they have to stop it. That is called a safety stop, and it is an automatic fail. Make sense? Okay, remember we have to have clean hands before we touch our patient. We cannot touch our patient until our hands have been washed. So we're not going to put that head of the bed up during our opening. We're going to do our opening. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to brush your teeth. Is that okay? Close curtain, wash hands. Once I've washed my hands, I'll get my barrier, get my supplies, and now I've got to put the head of the bed up. What could I use between my clean hands and that dirty bed controller? A paper towel, absolutely. And this is the step that we have to remember. This is a very important step on the test. This thing counts big. Refrain from touching resident before hands are clean. If I put the head of the bed up and slide that pillow down, I've touched that resident. Good? Good. So this is one area I'm working on. This actually is the video I'm working on right now. This is one of those areas, and I'm going to show you the old video because I don't have the new one done yet. But there is a difference between the old video, what it shows, and what I need you to do. In the old video, I put the head of the bed up before I wash my hands. Don't do that. We're going to follow the steps in the book. We're going to do our opening, wash our hands, and then get a paper towel to raise the bed. Okay?
And then can we pull the pillow down?
Yes, and
With
then
our hands first?
then you can, yep. Now, we don't have gloves on yet. We are going to wear gloves for this skill, but we don't have gloves on yet because we want to get all of our prep work done to keep our gloves clean for the patient.
But make sure you don't touch them as pulling the pillow down.
You can still, because your hands are clean.
Oh.
You can touch them.
It's just that remote thing.
Right, right. Yeah, the remote is really gross. Really gross. All right, we are going to use the towel over their chest. Now, let me explain this. A lot of people skip this step. It's not a critical step. You'll still do fine on the test, but don't do this. When you are brushing your teeth, you're doing it over a sink, and you're probably leaning forward because all of that goopy mess is going to be dropping down into the sink. You don't want it on your clothing. So you brush your teeth forward. Our patient is not forward. They're sitting up, which means that all of that foam is going to drop down here. We don't want it on their clothing. Give them a towel. Okay? Give them a towel. If you miss a step, it's not critical. It won't fail you. But if I were the patient laying in the bed, I'd probably throw something at you. You know, we're not going to be best friends if you make me all messy. I want to look good. All right. We're going to wet the toothbrush before we put toothpaste on it. This is just like your hands. You need your hands wet before soap for the lather to spread. You need the toothbrush wet before toothpaste for it to spread well. Otherwise, it just goops up. Guys, don't use a lot of toothpaste. A pea-sized amount is all you need. We get real in America, man, we get aggressive with that toothpaste. We do this whole stripe thing because that with these loops, because that's what TV show. You don't need that much. Do you know why they show this on TV? To get you to use more. Do you know why they want you to use more? So you buy more. That's exactly it. You need a pea-size amount. Read the package. It says a pea-size amount. Don't overuse toothpaste because your patient is in bed. You have to help them rinse. If you use a big stripe of toothpaste like this, they're going to be rinsing forever. Where do those evaluators want to be? Yeah, at home in their pools drinking a margarita. They don't want to be watching this patient rinse and 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 rinse. Little bit of toothpaste is all you need. And then you're going to brush. Now, let's look at this checkpoint. Brush the sides and biting surfaces of teeth and gum line with gentle motion. Does it tell us how long? No. It just says, brush their teeth. Brush the top and the bottom, the front and the back. And I like to brush the tongue. It's part of mouth care. Not graded. If you skip the tongue, not graded. Not graded. But brush the tongue. Brush the tongue. That's just the tip of the tongue is all you're getting. All right, then we're going to rinse. Offer resident cup of water to rinse mouth after brushing. Rinse. Provide resident an emesis basin or disposable cup to use for spitting as needed, such as after rinsing the mouth. So they got to have something to spit into. So we're going to give them water, and we're going to give them something to rinse or to spit into after they've rinsed. Now, in the video, you actually see me holding the cup up to their mouth. But I want you to read that first word. Offer. So you can offer them fluid. They may say no. I'm good. I don't see why they would, but they may. We're going to go with that. If the patient reaches up to take the cup of water to put it to their own mouth, that's okay. They can do that. but if they don't reach up, we're going to put the cup to their lips. Okay, good?
If they say no, we don't do no further action. Just report it to the nurse, correct?
Yeah.
And you can offer like a little, either paper towel or washcloth.
Yeah.
You know, when they spit,
We're gonna use the towel that's on their chest.
right. Okay.
Yeah, we're gonna use that towel. So we're gonna grab that towel and pat dry. Don't leave them a drippy wet mess. Use the towel to pat dry. Good, good. And then you do your closing. So this is mouth care. You're just brushing somebody's teeth. And they give you 12 minutes to do it. Don't rush this. Now, it does take some time to do your opening. It does take some time to get your supplies. It does take some time to get the head of the bed up and to get them prepped for mouth care. It does take some time to brush and then rinse and spit and dry. And it takes some time to clean up your equipment and put everything away. And it takes some time to do the closing. So they give you 12 minutes, but you can do it in probably about 4 to 5. Okay? Don't rush. You have tons of time. Don't rush. That's the biggest thing I need to get through to you, because when you rush, you skip steps. You forget. Don't rush. Good? Good. Okay, so I'm going to show you the video on this one, but please remember, in the video, I put the head of the bed up before I wash my hands. We're not doing that. The new video will be right, but I got to wait for my new computer. You can use her FedEx number.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good. How are you?
Wonderful. I need to do mouth care. Is that okay?
Yes.
Okay, I'm going to put the head of your bed up. And then I'll close the curtain, wash my hands, and gather my supplies.
Okay.
We'll get you to a full upright sitting position for safety. And if I can get you to lean forward, please. There you go. Is that more comfortable?
Yes, much.
Okay, I'm going to close your curtain and wash my hands now. I'll gather my supplies. I'm going to start with a barrier, and we'll place that on your overbed table. I'm going to get a towel, a set of gloves, a basin, toothbrush and toothpaste, and a cup of water. We'll prepare the toothbrush first. We'll get it wet, place a little bit of toothpaste on it, and set it in the basin. Mr. Jones, can I place this towel over your chest?
Yes, please.
Okay. And now I'll apply my gloves. Okay, Mr. Jones, can you open wide for me? I'm going to brush the back on the bottom. The back on the top. And can you bring your teeth together? And stick your tongue out for me. Thank you. Set that aside. Go ahead and take a sip. Rinse your mouth. Let me wipe that off for you. Another sip.
No, thank you.
Okay. Now I'm going to dispose of my cup, wrapper, and toothbrush. I'll be right back. I'm going to remove the towel and place it into dirty linen. Going to go clean the basin, and I'll be right back. I'll place the toothpaste in the basin, use the paper towel to open the drawer, and place the basin and toothpaste in the drawer. I'll clean up my work environment and go throw these items away. Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here? A magazine?
No, thank you.
Okay, your call light is right here. If you should have any needs, let me know. Can I adjust the head of the bed for you?
No, this is great.
Okay, I'm going to open the curtain and go wash my hands. After washing my hands, I'll think about my skill, make any corrections I need to make, and then tell the evaluator my skill is done. All right. Okay, any questions on that one? I mean, the whole video was like 4 minutes.
You just didn't need the closing part, correct?
You
Like,
all
already know the closing, but you just didn't add it in the video, correct? Like when you had to lower the bed back down or move
Oh.
the pillow back up.
So, okay, you're talking about the head of the bed at the end of the skill is all about patient comfort. So if they want to stay sitting up, they can stay sitting up. If they want to lay down, they can lay down. The head of the bed at the end of the skill does not have to be lowered. The entire bed, though, would need to be lowered if I raised it. So if I raised that bed up to a comfortable working height for me, I would want to make sure I lowered it all the way down at the end. But the head of the bed, that's just comfort at the end. It's safety at the beginning, but it's comfort at the end, whatever they want. They might want to sit up and watch TV or do a crossword puzzle or work on crafting or something like that. Have a phone conversation with a family member. They might want to lay down to take a nap or stretch out. They may want something in between because their back hurts. I don't know what they want. We can ask. Okay, good. Questions? Okay, we're moving on. Okay. We already talked about that. All right, last skill for today is respirations. This looks a whole lot like pulse. I mean, it really looks like pulse. Your steps are here. All of the principles that are involved, they're all spelled out here. We know all of the things that we need to know to do the skill, except for skill specific. I have a video on this. Down here is testing information. Somebody should be able to take somebody's respirations in 5 minutes or less. You're only counting for one. They give you 5 minutes to count for 1 minute. It's going to be a real patient laying in bed. Charting is required. Normal respiration values are between 12 and 20, but you can be off by 2 breaths in either direction and still be accurate on the state exam. What does that mean? If the evaluator, who is also counting, gets 16, and you get 14, 15, 16, 17, or 18, you are considered accurate. Guys, that's half of the range. This skill is not about accuracy. It's about knowing the steps. Good? Good? You're going to have an opportunity to count with me to see if you're accurate. Page 55 gives us our step-by-step instructions, care plan at the top, supplies at the bottom. Off to the side here, you can see the actual documentation sheet that's going to be used on the state exam. You can see a bigger version of this on page 168 of your book. It's a bigger version of the documentation form. Guys, make sure that you're going through these questions. Every skill has a gray box. Make sure you're doing those questions so that you know that you got the information you need about this skill. It's a great self-check method. All right, here's our care plan. Patient will be lying in bed for skill. Count the patient's respirations for 1 full minute and record your reading. So how long are we counting for? Why? Easy answer. Care plan said so. What if that care plan said 15 seconds and multiply by 4? How long would we count? Yeah, whatever the care plan says. So 15 seconds and multiply by 4. We're going to follow no matter what it says. What if it tells you to stand on one leg while you're counting the respirations? What are you going to do? Follow the care plan. It's Simon Says, guys. It's a giant game, as Simon Says. All right, so let's learn the skill-specific steps. First, we'll read the care plan. We're going to follow that. Care plan says patient will be lying in bed for skill, count the patient's respirations for 1 full minute, and record our reading. We're going to do our opening. Knock, knock, knock. Hi, Mr. Jones. My name is Patty. I'm your CNA today. I'm here to get your vital signs. We're going to talk about that in a minute. Is that okay? Close curtain, wash hands. No supplies necessary for this one. We're going to evaluate if we need gloves. I might. If this patient's got body fluids on their arm, I might. But chances are I probably won't need gloves for this. We do not want to tell the patient that we're counting their breathing. If I tell you, okay, I'm going to count your breathing, ready, set, go. Patients will either start breathing faster because somebody's watching, or they'll hold their breath. Either way, we're not going to get something accurate. So we don't want to tell somebody I'm counting your breathing. We don't want to tell somebody just breathe deep and even. We don't want them to know that we're anywhere near breathing. We're going to tell them I'm taking your vital signs. Now, respirations is part of vital signs. We're not lying to them. But we're also going to set this up to make it look like we're taking their pulse. And the reason is, if I've got a live person in this bed and I do my whole opening, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to get your vital signs. Is that okay? Close curtain, wash hands, and now I'm back. If I stand over this patient, ready, start. How weird is this for my patient? I am staring at their chest completely silently and not touching them. How weird is this? Oh yeah, it's really high on my creep meter. What are you doing? You can't do that to patients. It's going to make them super anxious. Their respiration rate will speed up. It's just not good. So when I come back to the bed, I've washed my hands. I am going to hold their wrist. I do not have the pulse. I'm literally holding their hand, guys. But they don't know that. They have no idea I'm not taking their pulse. This is much more comfortable for the patient. Do you see how different that is? So we do not want to tell them that we're counting their respirations. In fact, we don't want them to know at all. We're going to make this look like pulse. But this is actually a checkpoint. It says measure rate of respirations without providing instructions to resident about how to breathe. We don't want them to know that we're counting their respirations. Good? Questions on that? In and out is counted as one cycle. So that whole thing is counted as one. So it doesn't matter whether you count it on the inhale in the middle, or the end. Doesn't matter. The whole thing counts as one. So if you pick a starting point and you start counting and they're exhaling, it counts because the whole thing counts as one. Good? Okay. Make sense? In and out counts as one. Now, your patient isn't going to breathe that exaggerated for you. They're not going to make it easy. Breathing should be even, quiet, and kind of hard to pick up. If you notice somebody breathing, that's something that needs to be reported. Because that's not normal. You have no idea how many times she's breathing, do you? No. And you're sitting right next to her. It shouldn't be easy to identify normal breathing. Good? So now that we know it's not easy and we know we're being tested on it, how can we make this easy? We're all about easy. I'm going to give you a trick to use that makes this way easier to count. We're going to count for as long as care plan tells us to. In this case, care plan said 1 full minute. Our checkpoint says 1 full minute. So how long are we counting? 1 full minute. So we always follow that care plan. This care plan says 1 full minute. Bye-bye. If the care plan doesn't specify, you can use the whole 15 seconds, multiply that by 4 thing that we learned about with pulse. We do have to document. Documentation form will have a blank on it. It's a graded checkpoint. Just because you counted it doesn't mean anything. That's in your brain. I can't read your brain. You got to write it down for me to be able to use it. So you've got to document. You can be off by 2 breaths in either direction. I've got a whole lesson on documentation principles on page 48 that you guys can read. But let me go over with you really quickly something that we can do to help visualize respirations. If I've got this patient here, she's laying in bed and she's breathing, it's going to be kind of hard to pick up. Now, some instructors will tell you to put your hand on their chest. Don't do that. Don't put your hand on somebody's chest. Some will tell you to put your hand on their tummy. Well, you can do that, but this is pressing their tummy in. And yeah, you'll be able to feel the breathing, but the weight of your hand can interfere with good quality respirations. So while those can be used, they're not best practice. What you can use in the drawer at the side of the bed will be alcohol pads. And you're allowed to use this on the test. Take an alcohol pad, put it on their tummy, hold their hand, and watch that alcohol pad go up and down. As that alcohol pad goes up and down, that's 1. It draws your attention because it's movement with a contrasting color, but it's not going to interfere with their ability to breathe. Now, that's what you're going to see in the video. You're going to see me use an alcohol pad on the patient's abdomen. Now, you guys are going to count quietly in your own head. I'm going to give you lots of warning on the video. When I say start, you're going to see a clock on the video. When I say start, you want to count the respirations that you see. Now, what I've done on this video is I've made the wording. As he inhales, the wording gets big. As he exhales, the wording gets small. That whole thing was 1. Inhale, exhale. Now you can see his chest move too, but this just draws attention to it. Now watch the video, count how many respirations, and then at the end, we'll see how accurate you are. You're going to watch me document, and you can see how accurate you are with this particular skill. All right, Jake, go ahead. pass that out. Oh, this is the old one. Oh, no, it is. It's a new one. It's a new one. Okay. Good.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to get your vital signs. Is that okay?
Yes.
I'm going to close your curtain. Let me go wash my hands, and I'll be right back. I'll take one. I'll take one. Okay, Mr. Jones. I'm just going to lay this on your stomach for later. I'm going to elevate your forearm, keeping your elbow on the bed. And this will take me about a minute. I'll need you to remain quiet during that time, but I'll let you know as soon as I'm done, okay? And we're going to start. Ready, set, start. Stop. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Okay, bed's in the low position. The environment is clean. Here's your call light. If you need anything at all, just press that red button. We'll be happy to help you. I'm going to go ahead and open the curtain and throw my alcohol pad away and wash my hands. After washing my hands, I'm going to document on the sheet provided by the evaluator and then wash my hands again. After washing my hands a final time, I'm going to review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. All right, any questions on that? Did you guys get 12? So it's pretty cool the way I was able to do that to involve you in the video. Sure.
You mentioned about not making it obvious that you were checking the respiration. Well, the alcohol pad. So what are the things that ask you?
Okay, so let's talk about that alcohol pad for a second. And I can tell you this just based on experience. Okay. Alcohol pads are mystical, magical, and medical. So patients are somewhat familiar with alcohol pads. They're all over medicine. We use them for a million different things. So if a patient sees an alcohol pad, usually they won't ask. They'll just let you lay it on there. I don't know why. It's something psychological. They usually will completely ignore it. If they do ask, because sometimes you have inquisitive patients, if they ask, you can just say, yeah, I'll need that later. And they will say, okay. They don't press beyond that because it's something that they're familiar with. And then we just throw it away. It's the weirdest thing. I don't know the psychology behind it, but I do know that it works. Now, if you put anything else on their chest, if you put a pen there, if you put a piece of paper there, if you put a watch there, if you put anything else on their chest, you can't get away with it. They will ask, why is that there? What are you going to do? They'll ask a million questions. But an alcohol pad, for some reason, short circuits and they just accept it. I don't know why. Now, I will tell you that as you go through your career, you won't need that alcohol pad anymore. This is used mainly for new people until your brain is kind of trained on what to look for. But I do have some patients that breathe so shallow that I still use alcohol pads. If you got somebody that breathes very shallow and it's very hard to pick it up, alcohol pad is your best friend. Children, alcohol pad is almost essential because they breathe so fast. In order to actually see it, an alcohol pad is almost essential to get an accurate count. Okay, good. Any questions on the skills that we went over today? Any questions on the skills? All right, we're going to totally switch gears. We're totally switching gears. The last half hour of today is all about test registration. Now, we've passed out a packet of information to you and a single sheet. We're going to go through all of this in just a few minutes. But everything I'm about to tell you, I need to let you know where to find because you're probably going to forget a lot of what I say in here today. Remember, class 4 last 30 minutes. It's what I've got this down to a science, guys, on timing. Class 4 last 30 minutes is test registration instructions. You can always go back and review this. But you can find detailed test registration instructions on my website, 4YourCNA.com under testing. Makes sense, testing. Test registration instructions. I actually do a test registration on the screen here. I have a video on it. I do a complete test registration from beginning to end on the screen. And then below that, because the video moves fast, I have step-by-step slides that you can follow. So I have the video, and then I have a follow me slide presentation to help you with this. First thing we're going to talk about is this page on the front of your packet. This is our roadmap. This tells us how this whole process works, and it's not as easy as you would think. This is not as easy as you would think. That's why I need 30 minutes to go over this with you. So if you look at this, there's 4 main steps to this. There's 4 columns here. Step 1 is your background check. Step 2 is test registration. Step 3 is the email that you'll get from Prometric. And step 4 is getting your testing date. There's 4 steps to this process. If you do them in this order, it makes life so much easier. If you try to skip step 1 and go directly to step 2, you may end up with delays in your test date. I know some of you already work in healthcare and you've already got a level 2 background check. There's no way of checking this, guys. There's no process you can use. If you think that your background check applies, you can go ahead and apply to the test, but I'm going to show you why this may delay testing later. Okay, so keep that in mind. If your background check has expired, if it wasn't done through the right agency and it didn't go into the right filing cabinet, they're not going to find it. So I recommend that you get a background check unless you absolutely are 100% for sure that you've got one that works. We're going to go through this in detail, registering, and then we'll touch on these last 2 in just a minute. So everything is going to be done through prometric.com/exams/nurse-aid-FL. So all Prometric testing, if you're in New York, that's going to be exactly the same, except the FL would change to NY. If you're in Connecticut, this is exactly the same, except the FL changes to CT. Good? But for us, it's FL. Now, on your page here, you've got the old website. It says prometric.com/nurseaid/FL. If you type that in, it redirects you here. They have a whole redirect thing. So you'll get to this page no matter which site you use. Now, when you look at this page, at the top of it, you're going to see some contact information. I'll show you that in just a few minutes. If you scroll down a little bit, you see these 5 accordions. Application process, if you click on that, it tells you exactly how this whole process works. Right here. Tells you how this whole process works. So it has your links for your online application or the paper application, which I already printed out for you. That's what you have here in front of you. It'll tell you Prometric is going to process your application within 3 business days, and forward the information to the Board of Nursing. You have to have a level 2 background screening done. And then you're going to register for the exam, or sorry, you're testing at a regional testing center. We're going to put that on the application form. We do not do in-facility testing. So this tells you how the process works, which I'm going to break down for you in detail. So let me explain kind of at a visual level how this works. Now, I just made my last classes didn't have this. I tried to explain it verbally and got a lot of blank stares. So I'm going to try to do it with some images and see if this helps. The first thing you do is get your background check done. They're going to take fingerprints, a picture, and a signature. Go get your background check done, and then the background check company sends that to a place called the clearinghouse. Now, it goes into this clearinghouse because of a code that you have to use. That code tells it this is where your background check has to go. Good? Okay. When you get that level 2 background check in the clearinghouse, then you're going to register for the test. Now, it's important to do it in this order because of the next step. When you apply for Prometric's exam, okay, you send your application to Prometric. Prometric has to go to that clearinghouse to pull your background check. Once it gets that background check, it creates a package that it sends off to the Board of Nursing. If you apply to Prometric and they go to that clearinghouse and you're not in there, everything stops. Everything stops because they can't create a package without that background check. Everything stops. So if you work in healthcare now and you got a background check, but it wasn't coded to go into this clearinghouse, when you apply to Prometric and they look in the clearinghouse, they're not going to find you and everything's going to stop. Do you guys see how that would slow everything down? Mm-hmm. So unless you're 100% sure that you're here, go get a background check done. There's no way to check. So what ends up happening if you're not sure, if you're working in healthcare but not sure, you apply for the test with Prometric. Prometric looks here and says, nope, can't find it. They're going to send you an email. And that email doesn't say, go get a background check. All it says, if you look in number 3 here, column 3, you see where it says FBI background status, record not found? That's what you'll get. It'll say record not. That doesn't tell you anything. If you don't know that that means they didn't find your background check, you wouldn't know what the next step is. Now, hopefully, you'll get this and it'll say record found. Application complete. That's what we're looking for. Application complete. If you get something back that says application incomplete, you have to look to see, does it say record found or record not found? If it says record not found, they don't have your background check. You got to go get it done, which will delay the process. So once Prometric gets your background check and your application, they bundle it up, they send it to the Board of Nursing. The Board of Nursing, this is an eyes-on event, a human event. This is not automated. The Board of Nursing looks at your whole packet. They look at your background check, they look at your registration, they look at everything, and they decide whether you're okay to test. Now, if you had one shoplifting charge 15 years ago and you took care of everything and you were young and dumb, but you've learned from your mistakes and you've been on the straight and narrow since, they don't care about that. They couldn't care less. They know we were all young and dumb, just some people got caught. That's simple. Now, if you have 16 shoplifting charges and the last one was 2 weeks ago, they're going to care about that. Do you guys see the difference there? Okay, one shows a pattern. This is what they're looking for background checks. Once they look at your background check and make sure that you are safe to work in grandma's house around grandma's silver candlesticks, they will approve you for testing. That approval gets sent to Prometric, not to you. So you send your application to Prometric, they grab your background check, they send it to the Board of Nursing along with your application. Board of Nursing approves you and sends that back to Prometric. Good? When Prometric gets that approval, they're going to send you an email. It says, hey, you were approved. Doesn't mean anything yet. They're also, at the same time they send you that email, they're going to get a hold of one of the testing centers in your location, and they're going to say, hey, this person, Egypt, was approved. What kind of test date we got? And the testing center will assign Egypt a test date. Then they're going to email that test date to you. So when the Board of Nursing sends your approval to Prometric, you're going to get an email. When Prometric schedules your test, you're going to get an email. You need to make sure you're opening up all of Prometric's emails and you check your spam folder for those emails. Good. And then you just go attend your test on the test date. Does this help you understand the process a little bit more? All right. So we recommend in our area DTIS. It's also Deontis is their other name. They use the UPS store on Barclay. You can usually get same day appointments. You can go other places. I am aware that the sheriff's office in town will do them. But in December, we had about half of the class go to the sheriff's office to have their background checks done. And it was late November, actually. And some of them are just now getting their test dates. So take that for what you will. It is cheaper, but there does seem to be a delay of some sort. I don't know why. I don't know where. I just know that there's a significant delay. Because we're in May. It's like 6 months when it should be 3 to 4 weeks. Okay, so use that information for what you will. I know this works like within an hour. This single sheet of paper came directly from DTIS. I contacted them. And I said, listen, my students are having a hard time registering for the CNA test because you're asking them all kinds of questions we don't have answers for. So the corporate, they actually sent me to corporate. And corporate typed this up and said, can you please give this out to your students? Step-by-step instructions. I followed these instructions and registered. And it worked perfect. So DTIS.com. These are your instructions. So when you go to DTIS.com, you want to click on the box in the middle or the link on the far left to create an account. That's step one. You have to create an account before you register. Now, those of you online, take a screenshot of this. This is this paper that I handed out, the instructions. Take a screenshot of this so that you have the same thing that I just handed out. I put this up there for you guys. Moving on. All right. So now that we've got the background check out of the way, we're going to apply for the test. I have given you the paper test application. We're going to go through it page by page together. You don't have to fill it out today. You don't have to fill it out in here, but we're going to go through it together. Now, you can mail this packet in. You can just pop it right in the mail and mail it in. If you mail it in, this is the address you want to mail it to, but that significantly delays testing. So what should be a 3 to 4 week process moves to 4 to 6 weeks. Because you got to mail it, it's got to get there. And then somebody's got to open that envelope and type in all the information that's on your application. It takes longer. Or you can fill it out online, which is shorter. It's this exact same packet, just online. And that's what I have on my website is the online application. When you go on to Prometric's website, this is the first thing you see is their contact information. And I want to bring your attention to this right here. It says if it has been more than 5 business days since you submitted an application and have not received confirmation, remember it said 3, but they process them within 3 days. If it's been 5 and you haven't heard anything, you need to contact them. Don't wait 3 months. Just contact them. Pay attention to your timelines. All right, so we have the online application. It's going to be under candidate resources, your paper application and online application, but you also have a link here to track the status of your application as well. So if you're thinking it's taking a while and you want to see where you're at in the process, you can click that link. Sign in and it'll give you the information. Now let's get into the actual application. So what you're seeing here is the paper application. Paper and online do not differ in very many ways at all. There's only 2, and I'll get into that in just a few minutes. There's only 2 ways that the online application is different from what you have in your hands. We'll get to that when we get to those sections. So the first thing you see is a stop sign. So this is in your packet right here. Okay, so 2 pages in, right here. You'll see a stop sign. That stop sign says, hey, stop. Make sure that the name you put on this application is, in fact, your name, your real legal name. And you have a photo ID with that name on it and a second ID with that name on it that has a signature. So your photo ID can be a driver's license, an ID card, passport. Your secondary ID could be a military ID, a social security card, a debit or credit card, a library card that has a signature, but the names have to match. It is so important that they actually have a stop sign on here. Please make sure. The next section down here is asking if you are asking for ADA accommodations. So if you need a seeing eye dog or a sign language interpreter or something like that, there's a whole packet here that you have to fill out and take to your doctor to have completed for ADA accommodations. So this is where you would get that packet and print it out and submit it with your application. In that case, you have to submit the paper application. Now, down below that, we get into the actual demographic stuff. And you don't need to fill this out in this class. You can do that at home on your own, but you're going to fill out your contact information. Please make sure that the name you write in here is the name on your ID. Now, some of you have 2 last names. I know one person has it hyphenated and one person has it not hyphenated. Please make sure whatever you put in here is what's on your ID, because hyphens count. For middle names, you would just put the first initial of your first middle name. Okay. So like if you're Amy Dawn Marie Jones, you're just going to put Amy D. Jones. Okay. All right. This second page of the application up at the top, you've got more demographic information. You can fill that on your own. Let's go down here. This is where it starts to get a little tough, because these questions are not your standard questions. And most people have no idea what to do with this kind of stuff. So this section, it's the criminal and Medicaid, Medicare fraud questions. If you have a felony in your background, you need to see me after class. If you have no felonies in your background for number 1 and 2, check no. Do not put anything on the A's, B's, C's, D's, or E's. Just check no for 1 and 2. You probably want to do that now in class. Check no for 1 and 2. And then we're going to turn the page. And let me explain to you 3, 4, and 5. This doesn't have to do with the felonies. 1 and 2 have to do with felonies. 3, 4, and 5 have to do with something completely different. If you worked for a doctor's office and that doctor was convicted of Medicare, Medicaid fraud, and we have 2 doctors in our community that this happened to. So they fraudulently billed Medicare and Medicaid. The people in their office that helped them fraudulently bill Medicare, Medicaid, profited off of that and knew what they were doing, were also taken to court. Those people were charged. Those people are on a list of excluded individuals and entities, meaning they cannot work in healthcare ever again because you defrauded the U.S. government. If that does not describe you, check no for 3, 4, and 5. Do not check off A's, B's, C's, or anything else. No for 3, 4, and 5. If that does describe you, you need to see me after class because you will not be allowed to test. You'll have to go get exemptions and waivers and all kinds of stuff. All right, so now we're going to go down to disciplinary history. If you've ever been a medical professional in Florida or any other state, this would apply to you. If you've never been a medical professional, it's no for all 4. What they're asking here is, hey, were you a CNA in Indiana, knocked around some old people, got your certification taken away, and now you want to come here and do it here? That's what they're asking. Have you had disciplinary action taken in Florida or any other state against a medical certification? If you've never had a medical certification, it's going to be no. Now, I've been doing this a long time, so I get into these routines, right? So I just kind of skipped. I actually had a student in my class about 4 years ago. She had been an occupational therapist in another state and had been charged with professional misconduct and had her license suspended or revoked. So I just go through this really quick, and she's like, well, wait, hold up. This might be me. I have no idea who's sitting in my class. I actually had a doctor from Costa Rica that took my class, came to Florida and couldn't work as a doctor yet. She had to go through so she took my CNA class. I don't know who you guys are. I don't know what you've had in your background, so I have to go through all of it. Okay, so, but most of you should choose no there. Now, let's go down to criminal history. This is pretty straightforward. Either you have one or you don't. Do you have a criminal history? If the answer is maybe, it's probably yes. So it's asking, do you have a criminal history? The next question is, have you ever had any records sealed? This is expunged. You know, a lawyer charged you $5,000 to make it all go away and promised you no one would ever see it. Yeah, he lied. We will. We find it. Medical is the one industry that can unseal a sealed record. We will find it. Do not lie on this application. It will absolutely disqualify you. And the last question there is, do you have a juvie record? Like I said, we were all young and dumb. Not everybody got caught. Okay? They're not going to hold it against you unless you're dishonest. That's an ethics problem. Let's go up to page 4 now. Page 4, I cannot help you with. You have to read and answer those questions all on your own and then put your social security number in. I'm not going through that with you right now. You can do that on your own at home. But please remember that healthcare is stressful. Healthcare is stressful. It is not an easy job. We want to make sure that you don't have any underlying mental health conditions that could be worsened by working in healthcare. That's what those questions are all about. Be honest. All right. So if we go back to the very, very front page, I've got an important here in bold letters, and it says important. You must select E3 Challenger when registering. Any other option can disqualify you. So if you go to the top of page 5, you'll see I've already checked that off for you. I leave nothing to chance because by the time you get home, you'll forget that and you'll start checking other boxes. You guys are all challenging the test. 89% of all people in Florida that take the CNA exam challenge the test. You're in good company. Do not choose anything else, though, unless you are a lapsed nursing assistant. If you were a CNA and you let it expire and now you're trying to do it all over again, you can check E5. Doesn't matter. They're not going to ask for any information either way. E3 is good for most. Below that, it has your training information. I've checked, X that out for you. Do not fill that out. It asked for us to fill that out if we answered E1 or E2. What did we check? We did not check E1 or E2. This does not apply to us. Move on. Now we're going to come back down to test site information. I told you guys that we're all testing at regional test sites. We are not an in-facility. You are not going to test in this room. They use it for CPR and other things. We're not testing in this room. You guys are going to a regional test site. The closest one is in Tampa. So we're going to check off regional test site. Now over here on the paper application, it's asking for a code on the paper application. So here's your packet, right? Here's our steps. If you just open the page, these 2 pages are the test sites available to you in Florida. Now I have grouped them into regions because it just made so much more sense to me. I'm an organized, orderly individual. I want them organized. But if you go online to Prometric's website, you can click on Test Center List and they'll give them to you like this. There's no rhyme or reason. They're not organized. But we do have the Test Center List that you can look at. For us, in this classroom, our closest one is a Gillis, which is for you guys, the last one at the bottom of the page. A Gillis. Their code is CNA-TAMAIR. And you don't have to remember that because this first page here, I have it down here for you. Those of you who are in Citrus County, do I have anybody here coming to me from Citrus County? Your closest one might be Ocala. I've got that code there for you as well. Now, online, this is different. Told you there's 2 differences between paper and online. Online, this is different. Online, you don't have to have the code. There's a drop-down menu. You just hit the little thing, the menu drops down, and you just choose a Gillis in Tampa. There is another one in Tampa, but it's way over by 75, by Busch Gardens area. This one is closer to us. It's off the Parkway. It'll save you like 30 minutes of travel. I mean, unless you want to go to Busch Gardens after. I don't know. All right. So online, you'll get a drop down. If you're doing the paper application, just put in our code. Now we're going to get to the actual test part. So what kind of test do we want to take? Now this looks a whole lot more complex than it actually is. This section here, for most testers, you're going to click the first box or check the first box. For most testers, we're going to check that first box. Now, we got a lot of other options here. If you fail one portion of the test, if you fail the written, you only have to retake the written. If you fail the skills, you only have to retake the skills. So you'll see just the written and you'll see just the skills. That's for retesting. That's not for us. So for us, we need both parts. So we're going to check the first box. Now, some of you, though, especially if English is not your first language, you might want the computer to read the questions to you through earphones. So you're reading it and you're hearing it. This is really good for people who English is not your first language, or if you've got ADHD or dyslexia or reading comprehension problems. If you want the oral version where the computer reads it to you, you're going to check the second box there. Now, some of you, Spanish is your first language. If Spanish is your first language, you can take the written test in Spanish.
So for the oral one, do you have to have a doctor's one?
Nope.
You can just choose.
Anybody
what you
can
want to
choose
get
it.
written. Okay.
Anybody can choose it. Now, I will tell you, I've had students that have come back to me and said that the computer voice is really annoying. If you need it, use it. But if you don't need it, apparently because they can't do inflections. If they have inflections in their voice, it can lead you to the right answer. I mean, I can put up an answer here, a question, and just by the way I say the answer, I can lead you to the right. So these voices are flat. And students have told me it can be really distracting to them. So just take that advice for what you will. You can ask for oral and then decide you don't want it and put the earphones off. You can do that too. All right. So we've got basically 3 options. You can do the regular test, you can do the oral, or you can have the written test in Spanish. Make your choice. They're all the same price, $155. All the same price. So if you have to retest, then you would want to choose one of the single options there. Good? All right. So your fee is $155. Now, the last page here, page 6, you've got a box you have to check. That box says you have received and read their privacy notice. I've actually got it attached here for you. This is both sides. The privacy notice that tells you how they're going to use your information to clear you for testing. Tells you what to do if there's a dispute and all of those types of things. You can now check that box yes because you have access to this. Now below that is an affidavit. You have to read this, sign, and date. This just says that everything is true and correct to the best of your knowledge, and you agree to be a patient for somebody else that's testing, yada, yada, yada. Now down here is telling you that you should get an authorization to test within 10 to 14 days. Authorization to test is your test date. That's your timeline, guys. Business days, though. So about 3 weeks, 3 to 4 weeks. If you don't get your authorization to test in that time frame, you need to contact Prometric using this contact information. Open all emails because your test date will come as an attachment. Homework tonight. You got 5 and 6 because it's a weekend. 5 is on dementia. Pay attention. You'll have a lot of dementia patients throughout your career. 6 is on skills. We're covering skills in class. Read the paragraphs in between the skills. Wrap up emails will go out in a little bit. You've got your review sheet already. This is for the CPR class if you need to take a screenshot of it. You should do everything as soon as you can. If you do your background check today and register for the test tomorrow, then you should be testing about a week after graduation, which is perfect timing. Now, one more thing. I know I'm out of time. One more thing. There's one other change in the online form versus the paper. In the online application, there's going to be a box asking how you plan on submitting supporting documentation. So this is if you've got a criminal history and they want more information, how are you going to send it? You have to check a box. It's going to have mail or fax. I don't care what box you check. They don't care what box you check. You're probably not going to have to send anything in, but the application will not let you proceed if you don't check a box. At the bottom of the online application, you're going to have two buttons, save and submit. If you save, it knocks out all of your credit card information. You have to re-enter it. If you submit, it automatically saves. So if you hit save because you want to fill it more out later, you're not done, just remember, don't put your credit card information in. It won't save your credit card information.
And we're only paying for the 155, right? We're not
155. That's it.
But you already took it.
Yeah, unless you're
Yeah,
retesting. Yeah.
right.
Background is a fee.
I didn't know if the background.
Background is, I think, $76.18 or something like that.
Include that on the application, right? Just the 155.
Right. The
Okay.
background check is
That's
That's what I
separate.
was wanting to know.
Separate. Good. You'll want to remember last half hour of today's lesson. You're going to want to go back and review this because I went fast. All right, guys, have a fantastic weekend. I will see you on Monday. Do something fun.
Are you wearing a shirt today or you want skirt? Or really don't?
Shirt, class t-shirt.
I have a question not about the felonies because I don't have any of those.
Let me just sign off of online so they aren't hearing this. You guys that joined us online, thank you so much for joining us. I hope you guys have a fantastic weekend too. And until next time, happy caregiving. Bye. Okay.